You're listening to RideAlong, EMT School. I'm Mike.
And I'm Max. We're two students navigating EMT school, bringing you along week by week.
And I'm Jonathan, a paramedic bringing real-world perspective.
Join us as we share the lessons, challenges, and stories from EMT school, and hear insights from those already living the EMS life. Welcome to the RideAlong. Well, welcome to the RideAlong EMT School podcast.
We're back.
We're back again.
Every week.
Yes. Shady's
no matter
back.
whether you want it or not, we're back.
Again. Shady's back. Tell some friends. Guess who's back? Guess who's back? Guess who's back? Guess who's back?
Man, that's not even the best music reference in this episode.
No. As a matter of fact, you know what? We always forget to mention the episode name at the beginning. We wind up mentioning it like 10 minutes in. This one, we'll just throw it out there at the beginning. And we have this is another one that's a challenge for the audience. Because it's not a super well-known band and not a super well-known lyric. I know them. It's my wife's or was my wife's favorite band, but the tonight's episode title is "Close the Doors and I Am Gone." And man, I kind of want to talk about the song because it's perfect. The song is so perfect for EMS. Do you know which one I'm talking about, Max?
I don't. I'm not familiar with the band or the song.
Okay. Well, okay, maybe this won't be a challenge, but let us know if you like Thrice, because I got to see them live a couple times. I actually got a signed thing from them. And I fell in love with them as a band because of the song, The Artist in the Ambulance.
Which so good.
I didn't even think about as like a song. I'm like, we could have used this a million times between then and now. However, this one is perfect because we're finally talking about getting the patient into the ambulance. We're on that third part of EMS operations where we talk about closing the doors and leaving.
Like getting the patient to care.
Exactly. Like doing all the cool stuff. We have them in our space, right? Yeah. We're in our office now, and we do all the cool stuff. Granted, we did talk about some cool stuff in the last episode in terms of responding, because that's fun.
So when we're first pulling out, we want to get the ambulance up onto two wheels, right? Like that's the goal, is to get up on two wheels. And
that's why they make them so tall, 45. And they have a high center of gravity, is so that when you round corners, they really tip onto two wheels, and that reduces the friction, of.
And if you have a pregnant patient, depending on how you adjust her, it'll be better for the baby and her.
Right. Well, you want to make sure that you're always making right hand turns, because the patient should be on their left side.
Right.
Right.
Yeah, exactly.
Yeah. To make sure that the uterus isn't pressing down on the vena cava, right? Like it's anatomy, folks. This is how it works.
It's a thing.
No, but I actually listened to this song a couple times over the last week, and like the opening lyrics of like late nights, brakes lock, hear the tires squeal, red light can't stop, so I spin the wheel. My world goes black before I feel an angel lift me up, and I open bloodshot eyes into fluorescent white, flip the sirens, hit the lights, close the doors, and I am gone. Like it's like
perfect.
It's perfect. Like this is EMS. By the way, everyone should listen to Artist in the Ambulance. Great song.
But it sounds like we need to contact them and maybe use their song next season.
Oh, that could be our theme song instead of the Daughtry RideAlong anthem. By the way, there's a link for that on our. I think it's in our link tree. If anybody really wants to hear the whole version of the RideAlong theme song, which is the most epic podcast theme song in my opinion.
I mean, you need to hear it, people. The whole thing, not just a part of it. The whole thing.
It's so cheesy. It's amazing. And I did it on a lark before we even. Man, it seems like it's so long ago. Like 10 months ago when we were like, hey, we should do this podcast. I was like, all right, I'll throw in this subscription for an AI song generator. And now it's become our hallmark, is that silly song.
When we started, this beard was brown. Now it's gone white.
I got news for you, man. It was pretty white when we started. I don't know if you really. It was shorter.
It was shorter and narrower.
Yeah, you didn't even really have a beard when we first started, did you? It was like goatee-ish.
Yes.
Now you've reached your final form of Old Man Winter.
For those of you listening to this who can't see us, Max looks like a metal version of Santa Claus.
Yeah. Odin Claus.
Yeah.
Odin Claus.
If you don't know what that is, Google it. It's pretty awesome.
But yeah, so this episode we're talking about EMS operations. We're finally finishing up the trio. Obviously you can listen back to our last 2 episodes of Are You Ready, which is a Disturbed reference, and what was the last one? It was No Stop Signs, Speed Limits, which was AC/DC. So
yes,
we're now on part 3, finishing off EMS operations, kind of, sort of, because the next few episodes are going to be talking about things that still happen within EMS operations, but it's not like the day-to-day stuff.
Right.
We still have to talk about MCIs. Mm-hmm. We'll be talking about responses
Placards,
to
all that stuff.
Responses to terrorists. Oh, so there's like an ICS chapter. There's a response to terrorism chapter. I think there's hazmat in there too. Yep. So there's a lot of stuff. Oh, one of the things that we're going to have to talk about is flight operations.
Ooh,
We'll have to chat about that at some point. So all these other things that are part of like the system of EMS that aren't necessarily, treatment related. They're more like the logistics and the larger organization. And then, of course, we're ready and raring to go to really start hitting the test prep stuff. So we definitely want to do that.
Yep.
We're coming up with some plans on some strategies and some tools for you guys to really use that you can kind of do your test prep stuff with, as well as scenario prep, not just the NREMT, but for those of us out there that had to go through a psychomotor exam, we definitely want to give some tips and some strategies for that too. Probably even maybe like what I'm thinking is we'll probably have some like scenario playthrough on here that we can kind of proctor each other on so that we can practice going through psychomotor exams.
Absolutely.
It's hard to do skills though. Skills you got to do through your school. Like there is no substitute for the tool, like having the tools in your hand and bagging. And, that's all just a poor approximation of doing it in the real world. But hey, the skills nights, learning that stuff in school, all super important. With that said, why don't we kind of kick this episode off?
Yeah. What is your medical term of the week, sir?
With the medical term of the week, it's our setup segment, if you will. And this week we're talking about a concept that is very, very integral in this idea of patient transport. As a matter of fact, it's the kind of end goal of the patient transport, at least from our standpoint. Obviously, the end goal is making healthier and good patient care, right?
For sure.
But our job is, okay, we give initial care at the scene. We scoop those patients up. We give them great care on the way to the hospital. And then kind of the finishing line for us is handing them off to the ER staff or whatever facility that we're bringing them to.
Absolutely.
That's the core job of EMS and EMTs, is getting them to higher levels of care, right? So this week, the medical term of the week is transfer of care. So the definition of which is it's the process of transferring responsibility for a patient from one healthcare provider to another, while ensuring that all relevant patient information, assessment findings, and treatments are communicated accurately. But why? That's real, like, okay, all of that makes sense, right? But there's a really kind of core concept to this that is very important. It's almost like a secondary medical term of the week this week, because transfer of care is the thing that we really need to know. But why we do a good transfer of care is because of the continuity of care.
Right.
Continuity of care is an essential part of, really all medicine. We are just one part of the process, right? These patients are having a bad day. They're having a, some sort of acute episode, maybe an injury, an illness, whatever. They need us to get them from where they are to the hospital. with giving them life-saving interventions along the way if necessary, right? However, that patient is then going to go from our care to possibly an ER care where they're in the ER. They get the immediate treatment that they need from a higher level, a facility. And then from that point, they may be admitted to the hospital, right? They no longer need to be in the emergency room. All right, they maybe bring them up to a critical care unit, or maybe even it's like like something where they're just monitoring them for a couple days or something along those lines, right? When they hand them off to different departments, they still need to do this same process because they want everybody along the way to get all the information necessary so that that patient doesn't fall through the cracks.
Right.
None of the information gets lost. The treatments that they've had aren't repeated. The medications that they've had, if they weren't working, that they don't try them again, right? Especially if they had a bad reaction to them or they didn't get the response necessary. So the continuum of care is a very kind of core concept to all of medicine. And we're kind of the starting point of that when we're picking them up, right? So it's really about handing off all of that relevant information. And it starts from our point of being that kind of detective on scene. We've talked about that before, getting as much information about the history of present illness as we can, what that patient's been up to, what activities led up to what they've been experiencing, what their condition was on scene can be vastly different than how they're feeling or reacting when they're in the hospital. So that environment, knowing how they were acting, what information that we can get is vitally important so that the rest of the team knows how what happened to them outside of the facility. So, and all of that can lead to some practical things too. Like it could mean shorter stays. It can mean better care. It can mean less medical treatments for patients in the long run. So that continuity of care really just leads to better outcomes. So that's why it's so important that we do that, along with some other concepts in there in terms of safety and responsibility, which we'll get into in a second. But essentially, it's the idea that we as providers are taking care of a patient when we get there. Yeah, we're getting all this information, we're providing treatment, but that patient is now in our care. We are responsible for them. We're making sure that we're not giving them any treatments that they're contraindicated for, and we're making sure that we're giving them appropriate treatments for what they have, and that we're getting them from point A to point B safely. It's all part of that all the key responsibilities we've been talking about the last 40 episodes, right? But in a larger scale, like we are responsible for them, right?
Sure.
That's the key. So
if I can jump in for just
go right
a second,
ahead, Jonathan.
Yeah. So and I don't. We may have mentioned it on our podcast. I know that when we were on Chris and Spencer's podcast over at EMS 2020, one of them mentioned how at the onset of an EMS call, we get to give this one-on-one attention or this focused attention to the patient. And so you're gathering all this information, doing your assessments, doing your interventions, all that sort of stuff. And this is like the one time that this person is getting all that focused attention on them. And so you did all that. And so when you go to do your transfer of care, you really want to embody all those things you've done and provided for them up to that point, because it really can, as Mike has said, it can make or break positive outcomes for the patient going forward. So it's a super, super important concept as far as transferring care to another provider, whether that be another EMS provider or at the hospital.
Right. Because that's the next question we ask ourselves, right? All right, so I understand I need to bring this patient to somebody else, to some other place, perhaps. Well, who can I transfer to? Like, who is involved in that transfer of care? Now, commonly, this is one of the things like first week of an EMS, I think of EMT school, they went through this. And it's commonly kind of approached as you can transfer care to an equal or higher level provider, right? So as an EMT, if we have to hand off to another EMT, we can. If we need to hand off to, say that patient is now assessed and we're like, hey, we need ALS intervention, right? Like this patient they need interventions that are outside of our scope. okay, we're going to tag in that paramedic and we transfer care to that paramedic. However, so along with that, the most common one that we'll probably be doing is what we've talked about and what we'll talk about in this episode is transferring that care to a hospital, right? So the nurse in the ER, they are that higher level of care, right? They're the representative of the hospital. We go in there, they are taking the transfer from us. Those are the two things that we'll probably encounter most: handing off to a paramedic or handing off to the nurses at the hospital. However,
a helpful thing is when you take somebody into the hospital, make sure the person you're transferring care over to is that nurse. Sometimes it can get kind of confusing if you can't see somebody's badge or they don't wear color-coded scrubs. You may be transferring care to a patient care tech or trying to transfer care to a patient care tech or a CNA. And so most, like Mike said, it needs to be an equal level provider or higher.
Right.
So you got just make sure it is a nurse that you are transferring care to.
Right. It needs to be somebody with a medical certification, right? So that's probably the most common thing that we'll be doing. However, I did a little bit of a deep dive into this, and don't hold me to this. However, I wanted to know, is there other circumstances or things that we may encounter? Because it's commonly referred to that we can only transfer to equal or high levels of care. However, there are some circumstances that can arise where that isn't the case. And I just wanted to throw these out there just to know that really at its core, the idea of transferring care is not necessarily about following it needs to be higher level. It needs to be appropriate. That's the thing that we're really adhering to. Because for instance, if we're handing off care to a paramedic, we're handing off to them because it's most appropriate for a paramedic to handle this patient because they need interventions outside of our scope of care. However, even as an EMT, there are providers out there that aren't on the same level of us. So technically we're above EMRs, right? You could theoretically come across a situation, although rare, where say you're at some sort of event and you're the person that transports somebody from the stands or the crowds into an aid station or something like that, and there's an EMR in there who is not a transporter, somebody who can move patients, but somebody whose job it is to monitor patients, that theoretically could happen. Right. It's just to mention that in that situation, if that patient doesn't need higher level interventions or to be transported, which is where it kind of breaks into the EMT category, that EMR is appropriate for the level of care that they need to get. Same thing with if a paramedic was the first person to assess a patient and they determine, this patient doesn't need ALS interventions, it could be BLS. They can hand down to an EMT and say, hey, listen, you're going to take this while I go do this, take care of this other patient. It's the same principle because we're appropriate for what that patient needs.
Right. I do that all the time.
Yeah.
And the big thing, and this is going to be area and agency and state law dependent.
Yep. It's going to be different for where you're at.
Yeah. But the general idea in Virginia where I'm at is that as long as you don't perform any ALS level skill, as long as the call stays BLS throughout, then you can transfer over to a BLS provider.
Sure.
In my instance as a paramedic. So,
and this is just to throw out there that you may run into these situations, but it's imperative for us to critically think about it, to go, is this person that I'm handing care off to appropriate? And from our level as EMTs, as BLS providers, there's really not going to be a lot of situations that arise where we're not handing off to somebody that is more appropriate than we are, but we still need to think through those things, right?
Right.
So that's the key. We're handing off to an appropriate provider. But what should we do in that handoff? That is one of the things that we learned, a key concept in school, the verbal handoff. And it's imperative for us to do a good verbal handoff as a provider to another provider so that they're getting the key information that they need to be able to ensure the continuum of care, right? The thing that we were talking about before. So really it's if you really want to break it down into its most basic, the verbal handoff is really just a kind of 5-part story. It starts with who they are, so their demographics, right? What's their complaint? What's wrong with them? Why were you called to them? What did you find? Right? Like, oh, they called us for chest pain, but actually they were bleeding from their foot. Like sometimes you have those weird things that happen, right? What did you do? So what interventions did you give based off of what you found? And then how did they respond? Right? So you're kind of, it's a linear story in the sense that who are they? What happened? What did you find? What did you do? And then how did they respond? It's the timeline, right? So here's the example. It's a pretty good example. It may not always be this exact when you're doing a handoff, but you can hear those different parts in this example. So I've done this a few times as a lead provider or just as the primary provider for a patient like that I was in charge of. So handing off at the hospital those first few times can be a little bit intimidating because you're like, oh man, I hope I get everything in this that I was hoping to get, right?
Yeah.
As well as radio reports. And we'll talk about that in a minute, but it's very similar. Like you're like, man, I hope I don't mess this up, right? So handing off to a nurse at the hospital goes usually something like this, like, hey, Nurse Joy, because apparently I have Pokemon on the brain. This is Jake. Jake is a 52-year-old male with chest pain coming from home. Pain started about 30 minutes ago while mowing the lawn, and it radiates up his left arm. He has a history of hypertension and a previous MI. Initial vitals were BP of 168/94, pulse 104, respirations 22. Patient was pale and diaphoretic. We administered 324 milligrams of aspirin and assisted with 1 nitroglycerin. Pain improved from an 8 out of 10 to a 4 out of 10. Most recent BP is 154/88. Pulse 96. Patient remains alert and oriented. So there's a lot of information in there, but you can the main thing that you're seeing in there is a timeline. Who is this? It's Jake. What's the information about Jake? What did we find? Or why did he call us? Well, he's having chest pain. What did we find? Well, we gave the vitals that we found when we got there. He was having chest pain. What did we do? We gave aspirin and nitroglycerin. How did he respond? Well, his blood pressure improved. You know, he got the things that his pain levels decreased. That's the main thing that we were looking for. And then we got him here, and you could see the trends that were happening in that story, right?
Yep.
So that's the important thing. You want to try and get as much of that in there as possible. And depending on where you are, depending on your service, that may be more, it may be less. I would say the more you do this, you see on the simple stuff, it winds up being less and less as people get really, common or used to giving information. Things get a little bit shorthanded, if you will.
For sure.
For instance, I've seen a lot of times kind of truncating the vitals information instead of giving all the vitals, saying, hey, vitals were within normal limits, if that's appropriate, and then giving things that fall without or outside of the normal limits or any red flags that happen along the way. But that's the story. And we're giving a kind of comprehensive overview of from when we started to when we're ending with that patient and how they've responded in between.
Yep.
So that's the transfer. That's the verbal handoff. Now, there is one last thing just to talk about in transfer of care, and that is the thing that happens if we don't do it appropriately. And that's called patient abandonment, and it's probably not something we should ever do.
And you don't have to leave them on the curb for it to be patient abandonment. You could just not do your paperwork properly and can be considered such. Right.
That's the tricky part, because there are some nuances to patient abandonment. There's like the rules, like the kind of administrative side of patient. Like if you did not get this, then it's like, this signature at this time, somebody might consider that a patient abandonment. However, really what we have to take to heart is the idea that we are responsible for these patients. We have to make sure that they are we're giving a proper handoff to a appropriate level of care. And if we're not doing that, then we're abandoning them. Yep. And that is doing them a disservice morally, ethically, and physically. So we can't do that. We have to make sure that we're doing our full job, and that job also includes making sure that they get handed off to appropriate levels of care. Now, the example of this, where I hear a lot of people sometimes get caught up in this field, is the like, okay, well, we brought them to the hospital. Nobody would accept the patient. So we left them in the hallway and told the nursing staff, like, oh, that's where their patient's in the hallway right now. You cannot do that.
No.
And you
Definitely
can't
not.
leave. Now, if you have to wait with that patient at the hospital, you have to wait with that patient at the hospital until somebody takes the transfer.
Yeah.
That's where it's at. Like that's the biggest pitfall, or the biggest kind of like situation that I've heard of where patient abandonment occurs. Now that could happen in a bunch of different ways. Like if an EMT just gets fed up on the job and says, you know what, stop this ambulance, I'm getting out. That's also patient abandonment. You can't do that. Like, we have a duty to act. We are like, once we take responsibility for that patient, we are like morally responsible for making sure that they get good care. And until we hand them off, we're with them. Are there some exceptions to that? Maybe. Like if our safety comes into play, yes, there are situations where we are legally and ethically obligated to make sure that we do not add to the problem, that we do not get hurt. However, that doesn't really fall within the scope of patient abandonment. That's kind of, hey, we need to get out of here for patient safety, or for provider safety, and then we're still responsible for that patient. We're still like going to take whatever responsibility we can for them as soon as we are safe again, right?
Right.
So it's not really saying we're abandoning them. It's just saying we can't be with them if it's unsafe. And that's a gray area, I will admit. But so essentially patient abandonment, it happens after care has begun and before the patient no longer needs care. Like that's the scope of what we're talking about here. It's somewhere in that timeline. And if we walk away before appropriate transfer, that is patient abandonment.
One of the times that they let me do the transfer over, I did not get a signature on any of the paperwork because I was nervous and was trying to remember all the things that I needed to say. Yeah. I had a very understanding charge nurse and a very understanding medic that was with me and let me do all the things and let me walk away and then say, hey, you're missing something. Yeah. And then brought me back through it. Because it is intimidating the first few times for sure.
Now, here's an interesting thing. The signature, while it is required for our services and within the system that we're in, technically that is not, I mean, it depends on where you are. It's not legally the transfer. The transfer of care happens with our interaction with the other provider. Yep. So even if you accidentally didn't get that signature, I'm not advocating for this, and you should make sure you get all the signatures that you need to get because that's your protection in the long run. But as long, like the most important thing happening is making sure that patient gets the care transfer. And that happened. And I'm sure signatures get missed a lot more than what we would probably think.
Yeah, I have no doubt.
It does happen. Yeah. Sometimes you're in the middle of something, you're getting a second call, and you're the only ambulance that's in the area. Like it does happen, but you should do your due diligence and attempt to get all the signatures that you need. So
yep.
So that's my little spiel on my key takeaway of over the last few months of understanding the continuity of care and why we're important in that, and how the transfer is really it's integral into what we do. We have to do it. We have to get good at it because it is the endpoint for our patient care. It's
the finish line. Like you don't want to stop right before you get to the finish line. You want to go across the finish line.
Yeah. Although we'll talk about it some more, but there's definitely things that we wind up having to do after the transfer.
A few things. Yes.
But yeah, so why don't we kick into this into the chapter for finally finishing off EMS operations, the rest of the call.
Yes.
I feel, you know what's funny? Like we're now all experiencing this. We've all seen hours and days and days and days of calls, and like it's funny how all three of us. I'm so happy to say that all three of us have so much experience in this now that any one of us can handle this, and talk about this with experience. It's really cool to kind of look back and reflect on all the things that we've done in the past 9 months or 10 months or however long. It feels like forever.
It feels like it's been forever for sure. So we've got the patient, and now we're talking about getting that patient into the ambulance.
Oh yeah, that's probably pretty key to the.
It's kind of key. Like you don't want to leave your patient sitting on the side of the road, waiting for someone else to show up. The key is to get them in the ambulance so you can continue that care and you can get them where they need to go. And there's a couple of steps that are involved. One of the big ones is, what are you going to use? It's huge. Depending on what their house is like, depending on whether or not you have to go to the 5th floor or not. Getting the right equipment so that you can safely move them from wherever they're living to the ambulance. It could be as simple as bringing the stretcher into the house, lowering it down, and scooting them on and going on your way.
I mean, it could be as simple as just having them walk to the ambulance.
That's even better.
That's the easiest answer.
Oh, yeah, 100%. Showing up on a call and you think, oh my God, we need all the stuff, and this guy is in critical condition, all these things, and he comes walking out of his house.
Yeah, but the ones that I always like just take me aback are the ones where like the patient is waiting by the front door in a chair. They have their purse like on their lap and they have a cane. And
right.
Like you got to call for like, ALS breathing problem.
Yes.
You're like, oh God, this is going to be the one where we have to really get in there and like breathing is bad. It's the A of the ABC. And oh my God. And then they're just like, yes, I would like to be taken to this hospital, please. And
exactly.
Let's go. Come on. Like, oh, okay. Come on. Yeah. They're like waiting at the curb for you.
And the other thing you have to do is you have to package the patient. How are you going to get them from their house to the ambulance? It could be winter. It could be 2 degrees outside. It could not be. Are you going to just use a light blanket, or do you really need to get them bundled up? Is it raining out? Like, what are you going to do to get from the house with your device to the ambulance? How are you moving the patient to the ambulance? Same thing. Are you calling the fire department because you need a couple extra hands? Like, you should be doing that. When you get on site and you see what you're dealing with, you should call for this further resources if you need it. In our area, generally, almost every call I've been on, the police are on hand. So generally, you have at least 1 or 2 extra hands that are there.
In almost every call in my hometown service, the police list themselves as POI. And they don't show up, and POI, I believe, means point of information. So, it's basically them saying, "Call me if you need me, but I got more."
Otherwise, leave me alone. Yeah, exactly.
They show up to a lot of stuff, though. But
hey, donuts aren't going to eat themselves.
Exactly. And Wawa coffee is not going to drink itself either. So those two things are critical.
Listen, you know what? I can't even bust on cops because, like in EMS, the one thing that I will not pass up is any type of treat.
Yes.
That winds up being left behind. I'm like just. I understand. I understand shift work now.
And then loading the patient to the ambulance. There's a bunch of different equipment that you might run into. Like, you could be in a bougie service and they have these auto loaders and lifters and things, or you could be humping that guy into the ambulance, or it could be some kind of in between the two things. Again, knowing your equipment, knowing what you have, knowing where it is, making sure you have it so that you can get them from wherever they are to the ambulance so you can get them to further care.
Fun story. You know what I don't know how I managed to be this guy, but like, I guess it's because I'm new and I'm like, I still, check everything. I found, I was the one to find that the reef stretcher wasn't in the ambulance the other day. And I know I've seen it disappear a few times, especially if it's a call where they get delivered on the reefs.
Yeah.
And I've now found, like, in the last 3 shifts that I've been on, like, things that are like, did nobody else catch that? And it's because we're new at this. I don't think we're ever going to be as good as we are right now, like in terms of like checking boxes on stuff.
Oh yeah. No. We're right now we're new enough that those things are like burnt into our brain. And the service that both you and me have volunteered at, through the volunteer program, there is a separate check of your gear that you have to do every single time you come on shift, which I think is great because it gets you familiarity with everything that's in the ambulance, what's there, how it's stored. But yeah, it's fresh in our minds right now, but in 2 years, it may be not so much. But make sure you have what you need.
Mm-hmm. To that point, when you roll up on scene, that may be your time to decide what resources you're going to need and what transfer method you're going to utilize. So just as you pull up on scene, be thinking about that, right? I went on a call last week where immediately right off the bat, I was like, we need the stair chair. And you just be thinking about that because that'll save you some time.
For sure.
And one thing that I've seen too, because now that we all have experience in this stuff, I'm sure we're all jumping in all these different topics that we're talking about tonight. But one of the things I did not think about when I first started is like, okay, we have the Reeves, right? And there's a stretcher in the back. Well, if we're using the Reeves, why would we need the stretcher? We'll just take the Reeves, put it into, and then quickly realizing that like that's not how things work. Like you should not be lifting patients up into the ambulance.
No,
bad idea.
Use the device to get them on the stretcher.
That stretcher is like
100%.
the most like integral part of what we do, and it's like it should always be out of the ambulance. It should always be in the most as far as you can get that to the patient. That's that thing is clutch. And yes, I do think that being bougie and having auto lift or powered lift, lifters, whatever it's called in an ambulance is amazing.
Well, I mean, it goes to the point we talked about that before in previous episodes, like your health and your well-being. And the reality is, I don't care how perfectly you lift, you are going to take abuse on your body. Yeah, it's just a fact. And whatever you can do to cut that abuse down, you should do it. But so common options for devices, we talked about a few of them already. The wheeled stretcher, we've talked about that before. That's the key. Get whatever you're using to get them on the stretcher, to get them in the ambulance. Stair chair, we mentioned a few times. Again, if you have a bunch of stairs you have to go down, that's where it shines. Unless there's tight turns.
Way more stair chairs than I wound up using. Although I'm sure I'll hate them eventually. But like,
yeah. And there's times I've used it where I was like, why did we use this? But I defer to the experts. Backboards is another thing that we can use. We're not going to see that as much. See that a lot in vehicle crashes, things like that. Scoop stretcher is great if you don't want to disturb the patient because it can get put back together underneath of them. That way you're not disturbing them. Flexible stretcher, which I think is also a Reeves stretcher. Those things are money. Going down steps, they are 100% money. And then a carry chair, which I don't think I've seen that in our service at all.
It's essentially a stair chair.
That
I've seen, but like
it's an older device. But most of those have been replaced with stair chairs at this point.
Yeah. But the main thing we're talking about, all that we said it before, we'll say it again. Use the device to get the patient to the stretcher, and then use the stretcher to get the patient into the ambulance. You do not use the Reeves stretcher to lift them up into the ambulance onto the stretcher.
That's really high. Like
it's really high.
That would be silly.
It would be. It should be some kind of a challenge or something. And there's decision factors, things that are going to make you decide what you're going to use. One could be patient condition. Again, is it a vehicular crash where you have possibility of spinal injury? Then you might see the backboard used. Is the layout in such a way that you can't get the wheel stretcher in? You have a lot of steps, or it's just a really tight house. That's where that stair chair can come in. It could be the Reeves as well.
Those old construction homes with like the tiny little doorways and like, a bunch of steps up to a front porch that turns 90 degrees with no room for clearance. Yeah. Those are the ones where the stretcher does not enjoy that.
And I mean, even in new homes, some of these designs where, the bedroom's third floor. First floor is a basement, living room, second floor is kitchen. So you're going up to the third floor to get to the bedroom that you have to get him out of. And you could have these very decorative, pretty turns and everything to the stairs. Well, that's going to kind of make you decide what you're going to use.
Yeah, I never thought I'd be like, man, I would kill for some straight stairs.
Oh,
Like
exactly.
pivot.
And then you have terrain. Like, do you have to go across a lawn? Like, are you going somewhere where you're on a baseball field? And obviously the wheeled stretcher is not going to work on grass. Well, you got to get them from where they are to that stretcher is another option where maybe the Reeves is the right idea. The need for spinal motion restriction. We talked about that with the backboard. And then crew safety as far as like, well, first of all, should you be attempting this thing? Like, are you in a situation where this is a horrible idea where you are likely to hurt yourselves or hurt the patient?
Sure.
These are things that you have to keep in mind. And these are the things you're going to decide when you get on scene and kind of see what's going on.
Yeah.
And again, packaging, what packaging means. You're preparing the patient and device as one safe unit for movement. So you're doing it in such a way. So using all the buckles on the wheeled stretcher, like getting them secured in it so that they can't tip out. So they're secure in it. And then it could be dressing, splints, stabilization, whatever you have to do to make that patient safe and get them ready to go into the ambulance to be transported to the hospital.
Yeah, I think packaging, while I'm sure it's securement to the stretcher is one thing, but it's really about that, or at least from my understanding, what you're doing to them before they start moving, right? Whether that's on the stretcher or on the Reeves or whatever. Like, is it cold? Okay, well, maybe we need to bundle them in the emergency blanket or extra blankets. Are we throwing in some heat pads with them?
Right.
Yeah.
Is it raining? Are we putting on some things to keep them from getting super wet? Like all that stuff. Is part of the packaging and the securement. Like, hey, do they have longboard longboard splints on their legs? Like making sure that those are secured and when, like if they're if they need to be secured down to a backboard or anything like that. Like making sure that they're as bundled as possible for movement. Right.
Yeah. I had a patient last week that he had a shirt on, but he just had his underwear on, and getting him dressed was not really an option for us. Right. So when we put him on the stair chair, we made sure to provide some decency for him. We covered him with a sheet just to, and it may be something as simple as that, not necessarily the weather, but just to preserve someone's dignity as you're moving them outside.
Yep.
Yeah.
And there's some key goals in all this. First, obviously, is prevent worsening injury. You don't want to do harm. Whatever you're doing, you want to get them packaged so they're going to be safe to move. You don't want to have a loose splint that could then potentially wind up making the break worse.
Or like an arm sticking out from the stretcher, getting pinched in a doorway. Like something as simple as that is part of the packaging.
Yep. Maintaining body temperature is an important thing. Even if you're not going into, a cold environment, you still want to have them wrapped up so they're warm. Like Jonathan mentioned, protecting their privacy. You make sure that you have them covered in such a way that they're not being exposed as they leave the house going to the ambulance. And then preventing falls or movement during transfer. You do not want to put yourself in a position where that can happen, which is where choosing the right device and making sure you're not going over ground that you shouldn't be comes into play. And we talked about
in the transfer process, or in the not transfer, but the packaging process, moving them. I'm trying to think through what are the because there's reasons we want to cover them, right? I assume I've been pretty lucky. Right. Because every call I've been on, for the most part, we've been able to stay pretty close with the ambulance to the house or wherever we're at. But I assume that would probably be even more important if there's long transports outside, where we have to make sure that they're going across maybe a large parking lot, or optimally we always want to get the ambulance as close as we can, but I think that's probably a big part of this too, especially if the patient was outside in the first place. How do we make sure that we're making sure that they're not getting any worse, right?
Or you have a patient that's in a nursing home and you've got to go through a maze of corridors and, you're walking half a mile to get back to the ambulance.
Yeah. Or if there's
Well, and
or if there's courtyards, and sometimes
Mhm.
you have to travel outside to
Yep.
get around places or through places.
Mhm.
That's, I think, the bundling or the covering patients is probably going to come into play for that type of stuff.
Yep.
well, and another thing is the seat belts on the stretcher are not very comfortable. They're sometimes a little, especially if they've seen some service,
Right.
they're kind of rough, and so it gives a barrier to for sanitary purposes against the patient's skin, but then it also protects the patient from the seat belts rubbing. So
Right.
that's an important thing to consider.
Yeah, I didn't even think about that, but for sure, like a comfort factor in terms of like.
Yeah, they're not going to be
all those straps.
Yeah, especially once you tighten them down. That way their skin doesn't get pinched or bruised.
Yep.
Strap areas. Chest, hips and waist and lower extremities. So when you look at a stretcher, you have, I think, total of 5 straps.
Depends on the
to put
stretcher.
On a
Most
stretcher.
of them.
Yeah, like for the most part, they're going to have 5, like 3
5,
that go
right?
across and then 2 over the shoulders.
2 over the chest. So make sure that they're secured firmly, that they're not going to roll out of the damn thing. Shoulder harnesses should be used when available. I don't know if I've used any of those before or not.
So that would be the straps that come
shoulder
across.
straps.
Yeah, that's what they mean. And I've been in this for a minute, and I remember a time where we just had the 3 that went across the lower extremities and then the waist. And times have changed, and it is a liability reduction thing.
Right.
And sometimes the patient is not able to have enough muscle tone to sit properly in the stretcher, so you need to secure them in like that. So it's just something to consider, and you should be using them if they're available.
Yeah, I know. Go ahead.
No, because I feel even bad talking about this because this is one of those things where there is a safety device available.
Yep.
However, I also want to be true to the experience of becoming an EMT, right? What have we learned and what have we seen joining this environment or joining this industry? And I don't know about you guys, but nobody uses the shoulder straps. And I'm not saying that's right. I'm just saying that it's, or at least in the 2 services I've been in, they're never used.
Yeah. I've never
hit or
been,
miss.
I've
Yeah.
never been stopped from using them, and I've secured them a couple times. But overall, I have not seen them used.
I've been on calls where I've been like, okay, I'm fresh out. Like they said, hey, make sure you're strapping that patient down to the thing. And we had just learned in school, hey, there's 5 of these things. I got to make sure that they all fit. And then basically told, don't use those. Like, don't use those shoulder straps. That's silly. And I understand that is not what we should do. Like,
Right.
I'm just saying that like part of this process is also understanding like you have to follow the lead providers, and that's a tough place, a tough balance, like to be in a spot where you're like, but I've been told that we're supposed to do this, and you guys are telling me that that's superfluous and takes too much time. I would say do what you feel is best for your patients. Like that's how I roll with it. Like if it makes them more secure, I'm going to do it. Like if it provides better patient care, I'm going to do it. And I've gotten to the point now where I can be like, hey, so I know you're telling me not to do that, but I'm going to do it. Like,
Yeah, you should.
Yeah.
If you don't, and God forbid, there's a motor vehicle crash involving the ambulance, and that patient gets hurt because you didn't use those shoulder straps, it's a big deal. And there's lots of cases where that has happened, and there's negligence involved with the provider. So if they're on there, you should use them.
Yeah, there's no reason not to. Like, are you in that much of a rush? We're never really that much of a rush, seriously.
No.
There's always a little bit of time. We could put a seatbelt on.
And just a quick note, like even if you have a CPR patient and you're performing CPR, they still need to be secured to that stretcher before you start moving.
Yeah.
And in the heat of the moment of that, when you're running a code, I'm sure it's something that's easy to kind of overlook, but you got to make sure they're secured.
Especially because you're probably thinking, well, we've gotten them on here with the reeve stretcher and they're attached into the reeve stretcher. And then we put the reeve stretcher down. You still need to put that whole thing on the gurney and strap them all in together,
Yep.
So there you go. That's at least getting them to the ambulance.
Okay.
Okay.
Now we're in.
We got the door. We got there. We got the doors open. The patient's in there. We've chosen how to get all the stuff. We have all those fancy tools that you've been teaching us about, Max, over the past 40 episodes. The stair chair and the backboard and all that stuff.
All that stuff.
But I guess there's some things that we should do once we get inside.
No, you just hit the gas and go. Right?
Well, I mean, there's
Right?
probably I think there's probably some things we need to do inside the ambulance before that pedal gets hit, because things are going to move around a bunch. And
yeah, a lot. Yeah, that is one of those things that I struggle with, is depending on the driver. Like I said to the one guy, like, how do you do this with this stuff going on? And his answer was, yeah, just get used to the movement. I'm like, okay.
There is a I did not anticipate the fact that within EMS you have to have this kind of unspoken bond and trust with your partner and whoever's driving, that they are not going to screw you.
Yeah.
And I also now totally understand why there's people who get really angry at other providers when they don't drive predictably.
Yep.
And with a certain level of regard for those that are in the back.
Yeah.
Like that is verboten, right? I've seen people be like, that dude, fuck that dude. He doesn't know how to take a turn. Fuck him. Like serious anger. Like they won't work with somebody because they're like, he doesn't understand to not take the back road to the hospital. And every time we take the back road to the hospital, I get tossed around. It's got that tiny little bridge that, we slide out on. Like I literally had this conversation with somebody at my hometown service the other day of they don't like working with certain people because they don't know the best, most stable routes to the hospital. And they're like, I threw up in the ambulance the other day. I'm like, I understand now. I understand why that is such an important thing, because you have to trust whoever's driving because you're doing stuff in the back.
It's when we talked about our evoc episode and or in our evoc episode, it's, hey, you are driving and it is everybody's life is in your hands.
Yeah.
Yeah.
In that instance,
Literally.
Yeah, so it's super important. It's something that I don't play with. I usually try to prime the people I'm working with. So I'll use language like nice and easy to the hospital, or I'll even tell people if it's a little bit rough in the back, I'll be like, hey, you can step it down a little bit.
Yeah.
And you do need to communicate with your partners about that, especially if you're getting tossed around.
Mm-hmm.
Which leads us to our next topic of discussion during this episode.
Segue right in.
Yes. So, provider safety in the patient compartment. So, there are going to be a couple things that you're going to want to look out for. And I've talked about this on the podcast before, but it's worth repeating. It's one of my things that I try to do as much as possible. But if you are not seatbelted in as a provider, and you have the ability to do so, you are causing a risk to not only yourself, but to your patient. If, again, something happens and there is a motor vehicle crash or your partner has to take evasive action, it's a good way to get injured. So if you're able to, you should be wearing your seatbelt. And we've talked about some of the seatbelts, they're more like a harness system that allow a little bit of movement so you can provide care. And sometimes you just don't have a choice, right? Like it's tough if you're trying to provide good patient care. Sometimes, I was having to do that today, trying to get an IV on a guy going down the road, bouncing around, and but that's what he needed, and it happens. But if you can, you should be wearing your seatbelt just in case there is some sort of traffic issue.
Yep.
I think it's absolutely the most underutilized thing. And I'm just gonna point to my own experience in this. I'd say 95. All right, confession time. I've never worn a harness. I've never put one on in the patient compartment. I know that's not right. I'm saying I want to do better at it, and part of this is recognizing the things that we could do better at, right? And there's really no excuse for it because 95% of the time that I've been in the patient compartment, there's really no reason why I couldn't have been belted in. And I tell you that the only reason I haven't is because it seems like that's what people do. Like it's following the example of other providers.
It's a cultural kind of issue. And for me, it's something that I'm trying to be a good example. And anybody that's ever come to ride with me as a ride along or as a student, that's a big thing I harp on. The two things are, hey, you're going to stay, if we're out on the highway, you're going to stay in the ambulance until, we bring the patient to you, then you can do your assessment. And if we're in a moving ambulance, you're seat belted in. Mm-hmm. Those are two big things that I hit with everybody that comes and rides with me. And it's like I said, it's a cultural thing that I would like to see shifted more towards, people wearing those harnesses and those seat belts in the back more often than not. Again, sometimes you can't help it, right? You've got to provide care. But when you can, you should. In that vein, talking about belting ourselves in, right? Sometimes there's times where we can't, but we should. But there's never an instance where a piece of equipment should be left loose sitting about in the patient compartment. Absolutely not. And that goes for when we're responding and also when we are transporting, which is what we're talking about now. Anything laid about that's not strapped down is a projectile inside that patient compartment and has the potential to hurt and kill somebody.
Yes.
Right. Yeah. Yes. And listen, I know I've seen a bunch of stuff over the years, and in the same way, providers sometimes don't wear their seatbelts. Sometimes providers don't strap things down. I get it. Again, unless you're actively using that piece of equipment, it needs to be strapped down. And that goes for the oxygen cylinders, the bags, your monitor, anything that you might that you might have in the back that you're not actively using.
I cannot tell you how many times I have just looked at that heart monitor and went, that thing is gonna kill somebody. Because I don't understand. Like they make these like fancy, I'm sure they're super expensive mounts on the ambulances, on that little counter right by the CPR seat. There's on every ambulance, there's been a spot for the life pack, and it always sits on a bench seat.
I don't have an issue with it sitting on the bench seat, but there's a seatbelt right there. You can strap the thing in, and it should be.
I agree, but I'm just saying, granted, this is from one person's viewpoint in just a couple of services in one part of the country.
I've seen it all over though.
And nobody does it. Not a single person that I've wrote. And we have the opportunity, as the new providers, the new people coming in to be like, hey, why aren't we doing that? We should be asking those questions. We should be trying to encourage people to change, because there's really no need not to, no reason not to. Hey, if that monitor is going to be sitting on that seat, just take the seatbelt out and wrap it around the handle, just so that it doesn't become a flying object. But
the thing I think is hilarious is that I've seen it where it's in its mount. It comes out of the mount and sits on the damn gurney, and then they'll let it sit there the entire ride through, and then remount it once we get the person in the ambulance. And it's like, why not just leave it in the bracket until we're ready to take it out of the ambulance? It's a 10-pound projectile that'll bring you.
Usually, if it's on the gurney, I've never seen anybody put it on a gurney without putting the lap belt through the handle.
I would like to say that's the case for me. It is not.
Well, the biggest culprit is the first in bags. They always get stacked. So they're either in the footwell by the captain's chair or just on top of the gurney. Those things
Yeah.
never get strapped down.
No.
And they're like, oh, it's just a 30-pound backpack. That won't hurt
Yeah.
it. Yes, it
No,
will.
you're fine. It's soft. It's made of fabric.
soft.
To our listeners, you should be noticing a theme here. All right. So you may see some sketchy stuff, but you should not participate in the sketchy stuff. You should be strapping stuff down. It really is a thing of, it's a dangerous thing, right? To jump back a little bit, regarding being a provider in the back and providing care, that's a risk versus reward thing, as far as like, hey, you may not be protected by a seatbelt if you're providing care, but that's a risk that you have to weigh in the heat of the moment. But again, you should be wearing that seatbelt. So we're going to talk about getting the patient ready to transport them, right? They're in the ambulance. We've strapped all the equipment down. If we have the ability to use a harness, we're strapped in. This is where our patient care starts to continue, right? So we want to make sure from between getting them from the house into the ambulance that everything that we've done up to that point is still patent, right? So their airways still open, they're still breathing, they still have good circulation, good pulses. Any bleeding that you may have controlled, we want to reassess those things.
Mm-hmm.
Those are important steps, right? Because just by moving somebody around and jostling them, you could have loosened or removed whatever intervention you had in the first place. So we want to make sure that that's taken care of. The same thing applies to airways. If we used an iGel or we have an ET tube or something like that, we want to make sure when we're putting them in the ambulance that everything is still good from when we started that intervention.
Question for you, Jonathan.
Yes,
so
sir.
If you have a patient that's not critical, it's not something where you normally would assess things every 5 minutes, would you still say that there should be an initial assessment once you move them into the ambulance?
Yeah, and I think that can be a very rapid thing, and the more that you are getting experience, it can be an even quicker thing. So if I have a patient that again is not critical, and they're talking to me, well, they have a patent airway and they're breathing, and I can look at their skin tone, and that's going to tell me, hey, is their circulation good? So it can be a very, very quick thing. It's that whole thing of like at your from the door assessment, sick or not sick, you're still doing that throughout. Mm-hmm. And this is a time where you're going to continue to do that.
One of the things that I've kind of picked up over the last, I don't know, few months or so, is really getting comfortable with the idea that sometimes it's not always the same, and it could be situation dependent too. Like, for instance, we have a Wawa in town where we've responded a few times to like people that are, inebriated or feeling, crappy, these types of things, where it's like, okay, in that situation, let's get them into our space. Like, we don't need to be assessing in the eating area of the Wawa.
That's true. Yeah.
And like, hey, we make sure that there's no life threats, and okay, now let's get them into our, or same thing at like a clothing store, whatever. We've been there. It's like, there's no need to have all this onlookers and gawkers if we don't need to treat them here.
Right.
We let's get them into our office. Let's get them into a controlled space so that we don't have this kind of big open area that we then have to worry about as well, especially if there's no complications to moving them. So
Sure.
but then like if it's somebody at home and they're not urgent, well, yeah, then it would make sense that why don't we get our first set of vitals here on scene,
right?
And we could take a little bit more time because they don't need to be urgently transported, and we can start getting that trend early,
Right. And that's a great point. There's different thought processes on, should you initiate some of that stuff in the house and should you like rapidly load them in the ambulance and then start that process if there's, some sort of circumstance that's saying, hey, we should get them in the ambulance. And it's truly going to be a case by case basis. But yeah, this actually might be the point in which you start
get your first vitals or your first
your first set of vitals. Yeah, you'll get really outside of life threats. You may dive deeper into your assessment, right? May start into your secondary assessment in the back of the ambulance. So
even especially the interview, like as part of that secondary assessment, like you may not have had time, you may not have wanted to ask them questions in the location that you were in. Like some of that history of past pertinent history, you may not get some of that until you're getting them in the ambulance to a spot where it's like, hey, this is more appropriate to be able to start asking those things.
And my preference generally, unless there's some mitigating circumstance, right? Chest pain patients, I'm going to start my assessment immediately as soon as I make contact. But if it's not something like that or something critical, I may do the rest of it in the ambulance. That is my workspace. That's my office. I want to get them in there. I have more control over that environment than any other place. Yeah. One thing that, and this kind of out of order, but as we've loaded them into the stretcher, especially if you have an auto load, or even if you don't, you want to make sure that the cot is locked into the cradle. That's a big thing. You want to make sure everything's situated with that, because if that thing breaks loose, again, we've talked about it, it could be a very, very detrimental consequence if it's not secured. So we want to make sure that's secured. Patient positioning, that's going to be very dependent on the patient and what their needs and, their level of comfort. So sometimes you may adjust them to make them more comfortable, or sometimes you may have to sit them up. I find that with respiratory patients, oftentimes they need to sit up, more often than not, so they can continue to breathe pretty well. Laying them back is usually not a good thing for them. You may be, if somebody's nauseated, you may want to set them up so that if they do vomit, they don't aspirate whatever it is that they're vomiting up. So these are things, and I just learned this. One of my last patients that I had on my travel gig, we brought a stroke patient in, and they were talking about changing the elevation of the patient's head depending on what kind of stroke it might be. Now, in the field, on a 911 call, we may not know that, but in a transport setting, we may have an idea of what's already going on, and there's shown to be some benefits for laying the patient back as opposed to setting them up, right? For certain types of strokes.
Interesting.
And that's something new that I'm still learning about, but that was something that, hey, medicine's always changing, and you may have to do these different things in different positionings to address whatever the patient's needs are.
Right.
So, you may have to adjust your seatbelts so you can provide care. And the big thing is, if you happen to take a seatbelt off so you can get to something on the patient or get to an area on the patient, that you buckle it back before you start moving. That's a super, super important thing. We don't want those straps to be too tight. We don't want to restrict their ability to breathe, but we also want to make sure that they are secure.
I would also throw in there that, and this isn't anything official that we were taught, but just something that always stuck in my head. Like, if I need to undo a strap, make sure that all the other straps are redone. Like, it's one of those things, like, I try to make sure that never, like, if there's 3 straps on the patient, which usually there's 3, like 2 never come off at the same time. Like, get undone. Like, if I need to do this, if I need to thread something through or get access to a knee or a leg or something, where it's like, all right, before I take this second one off, I'm going to put the first one, re-snap the first one back in, just so it never gets to the point where there's 3, like all 3 straps are not on the patient,
Right.
Yeah. That'd be a bad day.
Yeah. It's like, you ever see those guys that climb like like really big things like radio towers or bridges and stuff, they always have 2 tethers on them. Both tethers never come off at the same time.
They do not.
It's always, there's always at least one attached. That's kind of how I think about safety straps. Like try to never ever let all of them come off at the same time.
Yeah. And this might be a time where if a patient has excess clothing on or maybe constricting things on, we may start to take that off or get that off of them.
Might as well.
Firstly, so we can assess them. And secondly, so that clothing or that object or what have you, that may be impeding them from breathing. So we want to, really, really stack things to our advantage in providing them care.
Not to mention the fact that it's our space, right? Like it's a climate controlled, super awesome box on the back of a truck. Like we can hit buttons to make it warmer for patients so that they don't have to wear the big bulky items so that we can do things easier. That's one of the benefits of bringing them into our space, right?
And you should be doing that depending on what's going on with the patient, for sure.
Yep. Yeah.
I mean, you don't want to cut the heat on if it's a heat exhaustion or a heat stroke kind of patient, but you also don't want to, freeze the trauma patient or freeze the little old lady, right? So adjusting that thermostat is super important.
So funny story. The one cardiac arrest call I've been on so far where we did CPR, it was a fall. It came through as like a fall victim ALS call. And on the way there, I was like, "Oh, that's trauma." I turned the heat up in the in the patient compartment. We were sweating buckets on the way because we were performing CPR the whole way from the house to the ambulance or to the hospital. And I remember halfway through, the paramedic was like, "Who turned the heat up?" I'm like, "That was me. I thought that's what I should do." And she's like, "Well, yes, but." Still, I'm trying to help.
There's one medic that I ran with, and he said any kind of a trauma, any kind of a critical case, that should be reading 80 degrees, and you should be sweating your butt off.
Yeah,
that was like his. If you're not sweating while you're in the back of this thing doing what you have to do, you don't have the temperature correct.
Yeah,
and that was kind of the barometer that he used.
There's a fine line between keeping the patient warm and roasting yourself in the back. Yeah. So let's talk a little bit about we've got potentially family members.
Oh, yeah, that could complicate some things.
Yeah, so sometimes family members don't have transportation to the hospital. We try to encourage family to either drive themselves or to have, another way.
Yeah.
Yeah. But you may, and it depends on your agency's policies. You may have to, transport a family member if you have the space available, depending on what's going on. They should, in general, unless there's a special circumstance, and we're going to talk a little bit about that here in a second, but in general, they should sit up front, and it is your responsibility and the driver's responsibility to make sure they are wearing their seatbelt, because you're responsible for them if they're in the ambulance. Yeah. So make sure that they put that seatbelt on. Special circumstances in which we may allow a family member or a caregiver to ride in the back. If somebody has some sort of communication issue, like I had a call one time where we had a individual that was riding a scooter and he's deaf, but he does sign language. And I don't know anything about sign language, but his family member could sign for him, and she could convey a little bit to us what he was saying. And so that was an instance where we allowed her to ride in the back. Again, those folks need to be secured in the back. Another instance would be a child, right? So if our patient's a pediatric, we might let mom or dad ride in the back.
Right.
And, traditionally, this is not the safest thing to do, but traditionally, for really, really little kids, we would have mom or dad sit on the stretcher and they would hold them. And fortunately, we have a lot of different devices out there that kind of allow us to safely transport parent and kid. And we have devices that allow us to safely transport a pediatric on the stretcher, right? There's a whole bunch. The one off the top of my head is called a PD mate. So it basically hooks into the stretcher, and then it's got its own little harness that the pediatric sits in. If you have those devices, you should be using them. Sometimes even.
Oh, sorry. Go ahead.
Yeah, sometimes even the captain's chair has like a fold down section, and there's a car seat or a harness booster seat type situation, and you can get a pediatric patient in that and secure them. So,
I just wanted to throw out there because like the one thing that they've emphasized more than most is it is not okay to have a parent hold a child in the ambulance. And I get it that's probably what things are usually happening, but
it's
just to put out there, like I would bet that there's probably NREMT questions of you should not do that. So
100%.
You know, just for everyone out there, like that is there are a multitude of options for making, like, you know, the built-in car seats in those chairs are one thing. Also, while, you know, if it was like a car accident and there's visible damage to like the child seat, you should not use it. But those car seats will go into pretty much anything that allows for a lap belt strap. So if it's somewhere where the car seat wasn't compromised, you could bring that car seat with you too. Like, you know, bring solutions. Like there's solutions out there for bringing that kid in a situation where they don't have to be held in the arms, because like you could just think of all the things that could go bad with like, you know, especially if the parent is the patient and they have some sort of episode where they're losing consciousness, what happens to that kid? You know?
It's a super unsafe practice that unfortunately, you know, some places are still continuing, but if you've got these devices available, you should absolutely be utilizing them. There's a common theme with what I'm talking about tonight, and it is that we need to make sure everybody's secure in the ambulance and all the objects are secure in the ambulance.
You'd think it'd be really easy just to tell people like, hey, make sure there's nothing insecure in an ambulance. Other than yourselves. Like, I'm very insecure.
It's this systemic cultural issue, and I'm fighting the good fight, and I'm advocating for folks to do the right thing. Your patients also may have personal property. You may have bags in the ambulance that are for securing that property. You may want to give that property to a family member if the patient's okay with it before you take that patient to the hospital. But at the end of the day, if a patient has personal property, it is your responsibility as much as it is your responsibility to get the patient to the hospital safely. So you need to keep an eye on that. And then if Mike talked about transfer of care, right? If you transfer care of the patient, you also need to transfer care of that property to the appropriate folks at your hospital. That may be a nurse, and then they can give it to security, or they may have a security officer there that's right there and available to give it to. If this is a motor vehicle crash and there are major injuries, but a patient wants an object from the vehicle, make sure that you communicate that with our law enforcement partners, right? Just so they're aware, right? Because they may have to investigate that, and there may be questions as to if something was removed or what have you. So just make sure you communicate that with the law enforcement officer. Make sure it's okay to do so, and if it's not, just politely explain to the patient, hey, they said that everything's going to stay in the car till they get a chance to check everything out. So, but that's going to be very policy dependent.
Right.
Hey, now we're actually getting into talking to the patient.
Oh,
come on now.
Right.
Talking to strangers?
I know. You got to talk to the patient. You probably have already been talking to the patient if they're awake and oriented. But just, an ambulance ride can be very, very scary for a lot of folks. Sure. They're having a bad day already because 911 was called for whatever reason. And sometimes it goes a long way just to be a gentle and encouraging voice to the patient. Mm-hmm. So just just make sure that you're keeping that in mind as you're going through and beginning your transport. Sometimes if you're not doing anything that's super critical for the patient, then you may want to talk to the patient about some different things, or they may want to talk to you. And it always is good to try and build a rapport with them. They're going to be more forthcoming with their health information, and it may be comforting to them to talk to them. It also lets you know kind of where their mental status is at. If you're talking to somebody and you're having a conversation and then they just start saying some off the wall stuff, or they start mumbling and it's not appropriate for the situation, that might be a clue that something is going on with that patient. So these are all things to keep in mind. Now this is going to be a little bit of a debated thing I'm gonna mention,
because I know where this is going.
Yeah,
and it's always been one of those. I have not encountered it yet, but I'm sure it happens. Is okay. Aside from parents with kids, what happens if we have multiple patients, or somebody's like, "I'm not sitting in that thing. I'm not sitting in that stretcher."
Yeah.
Because sometimes people are weird. Like, what are the options? Like, what else could we do?
Sometimes you will encounter people that don't want to sit it on the stretcher. I had a patient like 3 weeks ago, and it was a simple transfer back to her residence. And, typically this would have been done by a behavioral health car, and it's truly just a car with some added safety features. But that wasn't available that day, so an ambulance was sent, and I happened to be on that ambulance. And she was like, "Oh, I don't need an ambulance," so we allowed her to sit in the captain's chair, and she got belted in and secured. But in general, you should try and get people on the stretcher. The additional thing is there can be exceptions for MCIs where we may transport more than one patient at a time, depending on their level of need. If you're going to do that, make sure that your patient is secure on that bench seat.
Yeah.
I've had calls where we were limited on resources and motor vehicle crash, and we're transporting mom and we're transporting pediatric on a pediatric backboard that is strapped to the bench seat. And that's what they are designed for, but it's generally not a good practice unless there's some exigent circumstance that might cause you to have to do that. Again, these are things that are going to be very policy driven based on your agency's policies and guidelines. So make sure you're following those. But here's some things that you may encounter.
I got a question, because I'd never thought about this before. I don't know. Max is smiling too. I don't know. Like, am I the only one that missed the fact that the bench seat can be used to secure a patient laying flat?
Yeah.
Like, is that a thing?
It's not. It is a thing. It's more of an old school thing.
Wow.
Yeah. Well, and that was before we had auto load stretchers that like had these hard mounts in there. You guys have some services that don't have the auto loads, but they have the cradle. Okay. Is there like a thumb nut on the end of the cradle?
I'm not
like
sure.
Tying it to the floor of the ambulance?
Like a release thing?
Maybe. I
Well,
don't know.
So before a lot of the auto load stretchers and the power load systems that are like hard mounted in the floor of the ambulance, there used to be a set of like forks that would hold the stretcher.
Yeah.
But it had a thumb nut in it. Now you could adjust it, but sometimes, specifically during like an MCI, it could be said you're going to take that out, and then if you had backboards, you could stack two patients in there potentially.
Okay.
I'm not saying that's the best practice. I'm just saying these were things that were talked about and potentially done at different points, but it's kind of gone to the wayside. And also, a lot of ambulances are not coming with bench seats anymore. They're coming with
double captains or sideways chairs on the side. Yeah.
Yep, they're coming with chairs on the side, so you may not even have a bench seat to utilize that.
I just never even thought about it. I'm like, that makes total sense. That like if you have somebody on a backboard, you could tie that like that backboard can be secured to the flat surface with straps. I don't know if that's. I gotta read the ambulance instruction manual to see if that's something.
And let me say that or say this related to that. In the instance where it did happen for me, it was a pediatric backboard.
Sure, yeah,
right.
So I don't know if a full
seat, but
I don't know if a full size backboard would fit. I don't think so on most ambulances these days.
But it's, I mean, I just never considered it. It's something that's like, oh, well, that might be an option, or we might have to think about that. You got sometimes in EMS, you got to think outside the box, So.
Sure.
Yeah.
My question was coming from a video that me and Mike watched after last week's podcast recording. So what do you do when a random just stranger walks up and he says, I want to go to the hospital? Do you just let him come into the ambulance when you already have a patient on the stretcher? You know nothing about him.
Oh
man, that's going to be.
We watched the video and we're both saying the same thing at the same time. No, she is not going to do this.
Oh yeah, it was one of those. What was it? It was the New Orleans show.
Night Watch or whatever.
Night Watch or something like that.
I think I fell asleep.
Yeah. So we're watching an episode of Night Watch, and like they're treating a patient, and all of a sudden some other. I mean, he looked like either a drunk dude or
something.
Like he maybe had some mental health issues, and I think he was like he came up walking up to the ambulance. He's like, I gotta go to the hospital. They're trying to kill me. And they're like, well, hey man, you just call for an Uber or something like that. No, you got to take me. And they're already helping somebody. They already have a patient in the ambulance. He's like, no, you got to take me to the hospital. They're trying to kill me. And so they let him in and they take him to the hospital. I'm like, what this is crazy.
I probably would not have let him in my ambulance.
Oh no,
I there's no vaguely way. Remember this, but I was conked out on your couch.
Yeah. It was the most bizarre thing because the entire time I'm thinking to myself, okay, they're going to show what you should do if this happens. Nope, not at all.
No, not at all.
No. And let's leave a small female in the back of the ambulance with the guy that walked up probably had 100 pounds on her.
Oh, she was so tiny.
Easily. And it's like, and you're going to leave her back there. Oh yeah. The partner gets out of the back, closes the door. And it's like, you gotta be kidding me. This is anyway.
By the way, we had mentioned, I think in a previous episode, us watching Rescue 911 when we were younger.
Oh my God.
Let me tell you, it's a great time getting with a bunch of other guys who also enjoy EMS and watching William Shatner deliver.
It was the best.
Some Rescue 911 scenarios. Highly recommend YouTube Rescue 911. Yeah, you got to watch
Good stuff.
Yeah, it brings back memories. It's so cheesy. The reenactment stuff that they do in that, it's great. But
so to cap that off, if you were to encounter such a situation, policy is what you're going to follow first and foremost. But what I would do is, if my patient wasn't critical, I would have my partner get out and handle that, and then have them make a call to dispatch and get additional resources
that
there,
would be
whether that be law enforcement or that be, another ambulance. We would get some extra help there. If it were a critical patient, we may not be as, able to readily help that guy immediately. So
yeah.
This is what not to do. What not to do is to let some random dude walk up and get into the ambulance.
Yeah, who didn't call 911.
No.
Or you didn't get dispatched to that dude. You're literally now all of a sudden just transporting a second person.
And especially when first thing he says is, they're trying to kill me.
Oh, yeah.
They're trying to kill me. Like, there's so many bells going off.
That's one of those situations where if I was inside the truck, it would be like, where's the door lock would just go... Okay, sure thing, buddy. Yeah.
Oh man. So Mike, we've talked all the way up to the point we've talked about getting the patient in the ambulance. They're in the ambulance and all the prep work you have to do before we even start, transporting them. Why don't you talk to us about caring for the patient while we're taking them to the hospital, while we're en route?
We've talked about that enough the last 40 something weeks. Well, actually, you know what? There was one thing I think we neglected to mention, which actually we didn't. So, but at some point in here, we also want to make sure that we're communicating with our server or the system that we're in.
Mm-hmm.
Right.
And that's kind of where we can start this story here, because like we were on scene, right? We arrived on scene. We let dispatch know, hey, unit, whatever, we're on scene. We're taking care of the patient. We're transferring them into the ambulance itself. We're getting them ready. We're getting ready to move, doing all the things, starting to assess. At a certain point, we're going to tell our partner to be like, okay, let's get this thing rolling, right? That's the point where, okay, everything starts moving and a lot of things start happening in what could be a relatively short amount of time.
Sure.
Let me ask you guys a question, because I'm curious. Like, in your first due areas, what would you say is the average transport time?
15 to 10 minutes.
Yeah, 10 to 15 minutes.
Okay.
Depending. It depends on where I'm at in the county.
I think the farther in my first due in my hometown agency, I think it would be a stretch to say some of our farthest parts were 20 minutes away from the hospital. Mm-hmm. But for the most part, and we have two hospitals that we go to, one of which is 15 minutes no matter what, because it's all the way over in like Allentown, which is a farther distance away.
It's a geographical oddity.
Yeah. I'm like, I don't know why patients want to go there other than it's a different health network, and I understand that. But we have one really awesome level 1 level 1 everything, level 2 pediatric, STEMI, comprehensive stroke, burn center. Like, it's literally the God's gift of a hospital, right in our first due. And I would say most of our trips are about 6 minutes from the time we start rolling to the time we actually get to the hospital, which means I think we default a little bit farther to like, hey, let's get our first set of vitals and make sure our patients are stable or unstable before we get them into the ambulance. Like obviously, if it's like, hey, they need to transport, we're transporting them. We're going to load and go, right? But it means that we default a little bit more towards, if it's a residence, let's see how they're trending first, because we only have the 5 minutes we may not be able to get the second trend.
Right.
Right.
We will. We'll always try and get that second set of vitals before we go into the hospital. But it's like there's just not a lot of time to get all of these balls rolling, right? So this is what starts the process. Okay, let's start moving, and we might even be in the ambulance getting that first set of vitals, kind of doing an assessment before telling the partner to move. So the time in the ambulance is usually longer than the transport time, but that may be the time where you need to start getting some of that information before you say, okay, let's start moving, right? So that's when we tell dispatch, like, hey, we're en route to the hospital, right? Like, we're letting them know we're leaving the scene, we're moving. And from that's usually the driver's job at that point. But then it's up to the guy in the back or the gal. And I would assume most parts of the country, it's a 2-person role. Like, you have one person up front driving the ambulance and one person in the back doing everything else. It's like there's a lot of things that start happening there. And, obviously we started talking about the things that Jonathan brought us through in terms of like the beginnings of patient care, the primary assessment that we've done that on scene. We do the secondary assessment. We start getting those trends. We getting all that information before we start moving. Well, we still need to do all that while we're moving, right? We need to monitor if we have a critical patient. That's a 5 minute, every 5 minutes we need a set of vitals. If it's non-critical, every 15 minutes at minimum, although we're probably going to be doing it a bit more often than that. I've realized when we first started learning about EMT stuff and they said 15 minutes, I'm like, man,
it's a long time.
That seems really often to do 15 minutes. And now I think of it as an eternity. Like 15 minutes is like, you could do 8 sets of vitals in 15 minutes. But that's what we're starting to do. We're doing that, all the care that we've talked about. But okay, there's the care. There's the monitoring that's making sure the patients aren't, needing additional interaction or additional treatments. But now we need to start doing other stuff. One of which is notifying the hospital. And that may happen right away, and it may not happen right away, depending on where you're at. Like, you may need to get other things moving. However, what I'll tell you in my service is this is pretty much happening as soon as we start moving, or very soon after, because 6 minutes doesn't give them a lot of time for warning. And that hospital notification, we probably talked about it some on the podcast before, but it's really like we went through the basic gist of it in the upfront section of this episode in terms of the verbal handoff. However, the hospital notification really starts truncating that down, because now we start talking about how can we most efficiently give information over a radio or through a telephone, which I actually prefer using the phone than using the radio, because it doesn't tie up the radio and everybody doesn't hear me being a bumbling idiot. But either way, we're trying to get them the most important information we can in a concise amount of time. And this is why I think it usually breaks down into really the same story as the verbal handoff, but we're trying to make things a little bit more brief, and we're front loading the important information, because at any time technically during that notification, first off, let me just say this: the notification is a courtesy.
It is.
We don't have to do that. Like, it's not mandatory as part of this process. If you don't do it, guess what? They still go into the hospital. It's just not as smooth, and you will have a bunch of angry people at you when you get there. But we're notifying them to say, hey, listen, we're on the way and we've got something coming. You may want to prepare for it, or more than likely, they're just not going to prepare for it and they're just going to assign you a bed. And that's usually how it goes, is you get a number and a room to bring the patient to when you get there, and then they take the handoff. But sometimes you want to prepare them for other more, emergent situations that they may need to react to, right? So we're going to front load that thing with important information. So when we notify the hospital, obviously we need to give our call sign and our ETA. So I know this may seem odd, but those are probably the two most important pieces of information. How much time do you have and who's calling? Because even if you get cut off at that point, like, oh, shoot, I got to take care of this patient, at least they know there's somebody coming in, and they can probably look at the CAD system to go, hey, what was unit 47 coming in with?
Yep.
Oh, that's an ALS breathing problem. Like, let me call dispatch, and they can find out more information without you having to give it to them, but at least they know who called, right? So that you put that information first. Then it kind of goes into the regular handoff, like, what are you coming in with? Okay, let's get the demographics. It's a 78-year-old female coming from home. Sometimes it never hurts to get a little bit more involved into, like, where are they coming from? Because somebody coming from home, usually a sick person or a fall or something along those lines, as opposed to coming from a motor vehicle accident. That raises the hackles, right? Or raises the level of attention. Starts letting them know on the other side of the call, like, this is maybe there's a mechanism of injury involved here. Chief complaint, why are you bringing them in? And then instead of necessarily going into what we found, this is where what I've picked up doing is, like, this is where I'll insert, like, what I call the red flags. So, like, hey, we responded to a patient, 78-year-old female with constant chest pains. Hey, this is a cardiac alert. Just put it right in there to say, hey, listen, we're coming in because we have all the information here to say that we're probably going to need a STEMI lab or like whatever PCI lab, whatever facilities you have, or like raising the red flag for a heart attack patient. I'm going to let you know right away. Same thing for like a stroke scale. Like if we're responding to a patient with complaints of a stroke, I'm going to probably right up front say, hey, listen, they were 3 for 3 on the Cincinnati stroke scale. Right. So like so this is a stroke alert. We're coming in, and then go into the rest of the information, what we found, what were their vital signs, what was their mental status. But there's that list of red flags that I try to keep in my head to make sure that if I find these things that I'm letting them know right away. So like, if there's any life threats, obviously that's a big one. Like they can't breathe. Their airway is closed. Like those are the things that we need to let them know right away. Loss of consciousness is a big one. Like I've gone through patient hospital notifications, and then I thought, man, that was good. I think I gave them all the information, and always at the end of it, especially if it was a trauma or a head strike, it's always, did they lose consciousness? I'm like, oh, damn it. I forgot to mention that they did not lose consciousness, right? So always making sure that, that one's top of mind for me. Altered mental status is a red flag. Blood thinners. Like sometimes patients will deny you, or they'll try to say you can't come there because the patient's on blood thinners. If there's any trauma criteria, like I know in Pennsylvania, there's a whole algorithm of things that we need to look out for that classify patients into trauma categories. If those are present in any way, shape, or form, hey, we have penetrating trauma to the chest, I'm putting that right in that kind of red flag category as soon as I'm giving them information, because really all the stuff that happens after that is really not going to change anything for them. In terms of the notification, they're gonna start making the trauma stuff. They're gonna get people into the trauma bay and making that thing happen. And then we'll give the full handoff when we get there. So if there's anything on the stroke scale, cardiac symptoms, breathing issues, those types of things, we're putting those up front. And then after that, it's okay. So what's their GCS, what's their vitals. And usually this is where it starts getting truncated to like, they don't want to hear a bunch of vitals usually they don't want to hear.
They do not.
Like they're like, hey, are they stable or unstable?
Well, I'll say this. It depends on the hospital. It depends on the
hospital. Honestly, it really does.
My local hospital, unless something is out of the norm, they don't care.
Yeah.
And they stopped listening.
Yeah.
This incoming patient report, I like to think of it as your 30-second elevator pitch.
Right.
Yep.
To the hospital.
Let me sell you on this interesting patient that's coming your way.
Yeah.
Have you ever thought, man, wouldn't it be awesome to see a rebar sticking out of a patient's neck? Well, do I have the patient for you? Man, that would be amazing to deliver I'd be better at ad-libbing some stupid patient handoff than I am at actual patient handoffs.
You know what? You would make the nurse on charge laugh her ass off.
Oh, yeah, because it's totally what I want to be known for.
Right.
But that's why I think it's very important to kind of kind of front load. That's the word I'm looking for. Those red flags, because if everything gets lost after that, at least they got the most important piece of information, right?
And honestly, that's what they want to hear. They want to know what's going on that they need to address immediately.
Yeah. And then I will say that, what we definitely want to put in there, if we have time for it, is interventions and, what we had, like, hey, their SATs are 98% on 15 liters. Like whatever we can give them, say this is what we've done en route. But at that point, you may not have been able to give very much. So, and that's to say you could also call and follow up with more information if you need to, or take a break, because I've heard that happen too, in terms of like, hey, I'm going to start giving a patient or a hospital notification. And then you may have to stop and go, oh, I got to
Do a
I'm just
thing.
going to forget that thing and keep
Mm-hmm.
taking care of the patient because that's more important.
Yeah, if the red stuff is just pouring out of them suddenly, you shouldn't just calmly continue to give your report over the phone of everything you've had up until that moment. You should probably put the damn thing down and deal with what's in front of you.
We should not do that.
That's a bad thing.
I've had, and this was more when I was in EMT, but I've had patients that were so critical, and I'm driving, and my partner in the back's having to do something I'm having from the front to call and report as best I can.
Yeah.
And that's not ideal by any means,
No.
but
you do what you can.
They were so busy in the back that they needed me to do that just so there was some notice to the hospital.
Yeah, that cardiac arrest that I was on, like that was a driver hospital notification. Because all three of us were busy doing stuff in the back. Actually, we had a fourth person in the back, if I remember correctly, and all of us were busy. All of us were trying to do stuff, and none of us really the guy in the front's like, hey, what really do they need to know other than, hey, we're 6 minutes out from your facility with a 65-year-old female in cardiac arrest. CPR is in progress. Like that's
all they need to know.
All they really need to know, because when we get there, they're going to go into a resuscitation bay, and that's not going to change based off of really any other information. So yeah, we're gonna give them that hospital notification, hopefully sooner rather than later. Give them as much time as they can get, and then they may come back with more information. They'll ask you those very pointed questions of like, "Hey, did they lose consciousness?" No, they didn't. Sorry, forgot to tell you that one. Or like, they may even have like, what's their GCS?
Will advise on arrival.
Yeah. Thanks for this. Isn't 20 questions. We're on our way. Thanks. Bye. But yeah, they may come back with more information, and you may be too busy. Sorry. Like, we're doing other things right now. So we're going to do that. We're obviously going to provide any care that we need to give, all the things that we've been talking about. We're going to try to be as safe as possible, all the things that Jonathan laid out for us. We're going to try and do all those things at the same time while being safe. We're going to try and gather as much information as we can. It may be the only time that we have to have that conversation with the patient, trying to find out some of those things that aren't like the most important information that we need right away. That interview process, like, hey, do you have any past pertinent history for this medical condition? It may be the time where we have to dive into like, oh, so you're having abdominal pain. Do you have any issues? Have you had any recent issues with abdominal pain? What have your bowel movements been like? Have you been peeing? Have you had any infections? Like those types. Have you had this happen before? Did it feel this way? You may not have that time to ask the questions up front. So we start asking those when we have time en route, right?
Are you allergic to anything? Are you on any medications?
Right. Well,
the things that they might need to know once they get to the hospital.
Yeah. I mean, those are obviously important to ask. And probably if there's anything that we wind up that we make sure to ask, those are probably the biggest ones right away. But like I find that the past pertinent history, events leading up to, those two things can expand into an entire conversation depending on the patient. And because you're like, hey, what were you doing that led up to the chest pain that you're having? Well, in July, I saw my sister at the airport, and it's like, oh my god. This is going to take 15. This is going to be the whole ride to the hospital.
Yes,
this is the rest of this story. But like that's how they go sometimes. So it's like we got to get the most important information up front, and then they may take a little while to get us the interview information. Vital signs, we talked about that. We're trying to get them as soon as we get in the ambulance, and we need to get that second set somewhere in there so that we can show the trend on the PCI or the PCR. So that's important to do, and usually a requirement in any service is like you just got one set of vitals. You're gonna get chewed out for getting one set of vitals, right?
Yeah,
You need to get the double. You need to get both. and a respiratory rate. By the way, I don't know if anybody else. They're just giving everybody a warning out there. Like you need.
They're not all 16.
They're not all 16s. Like you need to get the actual respiratory rate, which for some reason always happened to be 16 or 18.
Lung sounds.
And lung sounds. Yes. I know in our charts, like it makes you, it will not let you close the chart until you have a respiratory rate on one of the vital signs. And I'm like,
Yeah.
there's a reason for that, is because we have to get it. Okay, so we're monitoring vitals. We're making sure that patient's stable. We're noting if they're unstable. We're making sure that we're calling that out. And we're watching the trends, right? Now, really, the only other thing to kind of, I mean, there's lots to consider in this section, but one of the things that we wanted to talk about was like any special considerations for the pediatric side, because that is always a bit more of a difficult situation.
Sure.
Like I know in the few pediatric calls that I've been on, it amps things up, and it really doesn't have to. But as humans, we just care more about kids.
It's just hard not to. It's really hard.
It's human nature, right? We always want to make sure that we're going to the nth degree for kids because they deserve it. And the things that we may be doing in that ambulance ride that, you know, we would neglect or maybe not focus on. I'll put it that way. Maybe not focus on for adults. We really need to be cognizant of for kids in terms of the emotional state and like their perception of the process and like comforting them. We may not be as cognizant of doing that for adults, even though I think a lot of us are very good at trying to do that and help, keep patients calm and being that kind of like, comforting voice for even adults. But for kids,
Sure.
we really need to focus on it, make them feel like everything's going to be okay. Maybe grabbing that teddy bear that's hopefully stashed away in the cubby in the ambulance. And really just helping comfort them. Like they're going to be terrified by the noise, the things that are going on. Like we need to address that and help them kind of get through it. And just being that calm, friendly voice can really change their whole outlook on all of that stuff. It could last their entire lifetime, is like that memory of, oh, that nice guy on the ambulance really helped mom or helped me, or, like you're really setting the tone there.
I had the pleasure of being in the back of an ambulance with my child going, and it was a pediatric centered hospital, and watching that EMT and how he interacted with my daughter. And I remembered that, and just a simple thing of like, what's your favorite TV show? Or if you have a preteen boy, what's your favorite video game? What do you like to play? And just having that engagement that takes their mind off of what is going on right now and focuses them on something that gives them pleasure, that they have good thoughts about. It completely can flip the equation, and you wind up with a patient that's engaged with you, that's not thinking about whatever's going on with them.
I'd much rather have conversations with kids. Because that's easy. Like I could be like, hey, what's your favorite Spider-Man?
Exactly.
And like sometimes I've gotten into conversations with adult patients where they've been like, oh, well, what is your favorite 16th century European author of? And I'm like, listen, man, I'm just the guy with a stethoscope that can push the NIBP button here on this monitor thing. Like I'm going to hit that now and hopefully it'll work. And I literally transported like an English professor, and he had this giant stack of books in like in a messenger bag. And I was like, oh, what are you reading? And I'm totally not setting myself up for success here, because the things that I don't read, but the things that I listen to are like Dungeon Crawler Carl, or maybe every now and then I'll have like a history book in there, like, oh, like John Adams or 1776. But I don't go much deeper than that. and he starts talking about like, oh, this is like French poetry from, the 17th century, and like, I don't know, French abbots and stuff. I'm like, oh, well, that sounds cool. Like, kids are way easier. Do you like baseball? Oh yeah, baseball's fun. Yeah. What position do you like to play? Like, that's way easier.
Yep. I had a conversation with a 65-year-old lady about Minecraft because she had her grandkids over, and I asked her, so what'd you do with the grandkids today? And we had this 10-minute conversation about Minecraft with a 65-year-old lady, and she's telling me all completely enthralled and excited about it. And it was with an old lady. It was pretty cool.
All right, so that is kind of, we're juggling a lot of stuff on the drive, and it could be short or it can be a bit longer. I'm sure there's services out there that regularly have to transport patients over, 90 minutes if they have to, depending on where they are. That's probably where the gift of gab comes in, and being able to kind of, have some sort of interpersonal reaction or interpersonal, interactions with other humans. I'm looking at you young kids nowadays that don't know how to have conversations. Please put the phone down and actually talk to people. It'll save you a lot of, or it'll be very beneficial for you. Trust me.
Yes, it will.
Hey, don't sell the young providers, out just yet. I've seen some really, really good young
great.
EMS providers.
Yeah.
Do good jobs at talking to folks. So.
I'm not putting the age category down. I'm just saying of the behaviors I've seen in this field, having like not being able to carry a conversation because you're more comfortable sitting around in groups but being on your phone. That is your opportunity to put that thing away and to have those interactions with the people around you, so that the job is better, so that you're better at having those conversations. Because, man, I get it. I love phones. They're amazing. They like, especially for my ADD riddled brain, where it's like, I'm bored and let me go on the phone and look at Instagram for a bit, and then totally forget about what I was doing. That phone doesn't help at all. With the
not
EMS
the back
stuff.
of the ambulance.
Yeah, like that needs to go away completely. It is not part of that equation.
Nope.
And the more we can move away from those things, the better we're going to be as providers. So
100%.
That's just my 2 cents. My takeaway, things that I've learned about this that make me better. Hopefully we're sharing those. But yeah, so that's the transport. But we pull into the hospital, into the parking lot. Our partner probably gets on the radio and was like, hey, dispatch at hospital. And then I hand it off to Max to tell us what happens then.
What you do is you open the doors, you hit the release, hit the brakes, and you send that critical patient directly through the doors into the ER. I've seen it on the TV.
Well, that
show
wouldn't
before.
work, though.
I've seen it work.
Because you have to hit the gas. The gas makes them go out the back. The brakes make them go out the front.
You're right. So you hit it depends. You go backwards and you.
Okay, I got you. If you were moving backwards, hit the brakes, then they would come out. Okay,
the key is to make sure you have the doors open first, though, because otherwise it's not really going to work. I can see that.
No,
but you got to work together. It's shake and bake. Come on.
Yeah, exactly. It's about working with your partner, figuring out what works. But no, all jokes aside, this is where you've done all the things. You've packaged the patient. You've moved the patient. The patient's in the back of the ambulance. You have given them the care. You have done your assessments. You have called the hospital, but now you're there. You've arrived.
Yeah.
And this is where you're doing that handoff to the emergency room. But the first thing you have to do is get them into the emergency department.
Yeah, if that's where you're bringing them to. Because you may do interfacility stuff where you're not bringing people into a hospital, but hey.
One thing that I will say is it does help to be somewhat familiar with the place you're taking them to, wherever 100%. It winds up being. Because I was allowed to wander the maze with a not critical patient, and the two guys that were with me just let me go because I had no idea where I was going. And there aren't necessarily signs saying go this way because they're expecting you to have some familiarity with the place you're going to.
I would bet that you're probably not giving those signs enough credit, because I would bet, like, in most hospitals there are signs, whether or not they are obvious or understandable.
You're probably right.
Is another story entirely.
Yes, but know where you're going. Like if you have that time where you're a volunteer, take the time to pay attention to where you're going, because hospitals are mazes. The main thing is that you cannot leave until that patient has been transferred. We already talked about this. You need to do the handoff. You need to get that transfer done to the hospital, and give them the information they need so they can take care of the patient.
Mm-hmm.
And if you leave without that, it can be considered abandonment.
Right.
So this is where it's really important to do all the things that we talked about before. If the ER is busy, you may wind up being with the patient in the ambulance before unloading them. Like make sure that they're ready to receive you. If it's gonna be a minute, you may wind up staying in the ambulance versus sitting in a hallway.
Well,
in an emergency department.
Let me clarify that, because I'm not aware of a situation where you're told to not get out of the ambulance. Like we don't ask them if they're ready, but you may be in a hallway, right? I mean, is it different?
I've never seen it for every single time that I've arrived at a hospital. We're wheeling directly in, like we're going in. We find a nurse that comes to us. She tells us which bay we're going to, and that's what we do.
Yeah, I'm just saying I don't think there's ever a time where they're going to keep you in the ambulance. But you may wind up waiting.
Yeah,
that can happen.
Has it? I've never seen it. So
in the ambulance is more a rare instance, but it has happened. Sometimes there are things going on in the ER where it's just not.
Yeah, they may be so backed up that they're like, "Hey, we need you to hold here for a few minutes."
Yeah, okay. Yeah. Or traffic, like the way that our local hospital set up. Traffic can get backed up in the ambulance bay, and there's not a good way to get the patient in. Right. So sometimes that can be a holdup. But yeah, like you may end up holding a wall in the hospital for a minute. That's typically, if you're going to wait, it's usually going to be that way.
Yeah, and they're going to tell you where to go.
Right.
And they may tell you, like, hey, you need to wait in this hallway, or they may, like, I've heard stories back in, like, COVID, when there were patients coming in and they would have to not dump the patient in chairs. That's what they would call the process, but there would be nurses that would take handoff, and then patients would be put into the waiting room instead of actually going into hospital beds.
I've done that. I've done it already twice.
Oh, okay.
Where basically, like, they said, okay, you're gonna go to chairs, and I looked at them like, what's chairs? And then she politely explained to me where we needed to go. And in that case, we wound up staying with the patient until, the triage nurse came out and started talking to her.
Yeah. Like, we have to wait until the handoff, but they're going to determine where you're waiting.
Yep.
And hopefully they're going to have a bed for you, because they know that we've got, we're also providers that need to go do the job that we're meant to do, but may not always be the case, right? But usually I've never seen it anywhere but inside the hospital, and actually I've never actually been held in any of the calls that I've had, like where I haven't had some destination to drop that patient off at with a nurse relatively short behind to get the transfer going.
And sometimes you have transfers that are not routine, and we talked about that earlier, like you're going to a trauma bay. Or a resuscitation bay for cardiac arrest, or maybe they're taking you directly to the cath lab. You may take that patient directly from your ambulance into the hospital, up the elevator to the cath lab. If
that's where they're telling you to go, that may happen. I did it. I've had one go straight to an MRI, and one go into the trauma bay. Which, man, is that wild? We'll have to that is like seeing that orchestra in process is really cool. One of the more impressive things that I did not expect to see and had no idea existed until I started riding on an ambulance.
Yeah, we did a transfer as well to an MRI for a stroke patient. So, I mean, it may not be something that's routine, or it may be something where you're in the hallway waiting with the patient, waiting for a bed. Like you're going to find out what you get when you get there.
Yeah.
One of the things, you're going to be doing is you're going to be helping the ER staff move the patient. So in every case that I have had where we have gone into the ER, we are generally the ones that are physically transferring the patient from our stretcher to the bed. That's been the case almost every single time. But it's also, every time I've been there, there's been 3 people. So we just wind up moving the patient and taking charge of it. Mm-hmm. And you're going to continue to care for that patient until you're relieved. So if no nurse comes, you're staying with that patient, even if you've transferred them over to the hospital bed.
Yeah, or you're going to be doing that thing where you stand outside their emergency room, tapping your foot, looking at your watch, going, "Hey, is somebody going to come over here?"
There is some kind of thing that nurses learn where they can act as if you don't exist. It's something they learn in school. I don't know what it is, but I have been there, and I'm not a small individual, and they are literally looking through me onto a monitor. Like I'm standing here, like, and no interaction whatsoever, because it was not her job to interact with us. She was doing something else.
Everybody, Max's opinions are of his own, and any hate mail that you have from a nurse can go straight to Max, because we do not share all of Max's opinions.
We'd love to hear your hate mail.
Well, Max got one thing wrong about that. That's not something they learn in nursing school. That's something they learn on the job.
Got it. Now it's clear. I understand.
Just like we learn to hoard Uncrustables in our cheeks when we leave the hospital. That's a learned behavior. That's not. They don't teach us that in school.
Yeah, the chocolate eclairs that you put under the blanket when you grab 5 of them instead of just one.
Wait, yours has chocolate eclairs?
Yes.
All right, we're gonna have to talk about that.
Ice cream, chocolate. The ice cream bars. They're awesome.
Oh, I got. Yeah.
Oh yeah. And then again, you're going to give your verbal report, and Mike talked about that with the medical term of the week. You're going to break down everything that has gone on, so that you're giving them the information they need to continue the care. Mm-hmm.
I assume there's probably some signatures and paperwork that we need to get in this process.
Yes, 100%. So you're going to get a nurse to sign off as well. Most services, I'm sure, have a sheet that they sign off on. You're going to have the same thing from the patient as well. If they're able to, usually get them to sign off as well.
Yeah, we have a state form here in Pennsylvania. It's the same one at all the basically all the services have it. And what's interesting about it is, depending on the patient needs to sign it. It's their acknowledgement that there is, that they're being transported. They consent to care. But when you get to the handoff at the hospital, the nurse has to sign it. If the patient is not cognizant, or if it's a minor, or if they have altered mental status, they have to. Right. You also have to get the nurse to sign off on the consent for care as well.
Right. Yep.
It's all usually on the same form, I think.
Yep. But. And then you got the PCR, which is the pre-hospital care report. And that's basically where you're filling out all the information, whether their vitals, their name, any allergies they may have had, any medications they're taking, and get that all filled out as well.
Yeah. And usually we're getting some sort of registration number or like a sticker or something like that. I assume there's hospitals and systems that work completely differently, but
I have no doubt.
That's going to be very dependent on the hospital system. Locally, we used to do that, and we don't do that anymore. That's something they do like via fax back.
Sure.
Yeah.
But
at this point,
it's just to say that depending on where you're at, you may have to get other pieces of information. You might have to get like a hair sample from a doctor. I don't know. Like,
like I know in our service,
let me just get this, and then just walk out. I don't know.
Excuse me, just hold still. I just need to take a clipping of your hair. I'm sure that wouldn't freak anyone out.
Sorry, my boss told me I have to get this.
If you go to a nurse and I need to get a clipping of your hair.
Yeah.
The other thing too is, I know in our service we generally want a photocopy of insurance card and license,
if you can.
If you can. both of the hospitals that we go to regularly, there's actually a copier right by the doors as soon as you come in. That's kind of tasked for that purpose.
Yeah.
And then you have the personal effects. You want to be able to transfer those over to the hospital, to the nurse in charge, and make sure that's documented so that you're no longer responsible for those items, and you can give them to the staff.
If you're out there and you've forgotten a patient's items in your ambulance while bringing them to the ER, let us know. What did you forget? I've forgotten a bunch of stuff. Remember that satchel full of books that I told you about? That was one of them.
Yeah, for me, it was the laundry list of medications that had been so carefully copied for me to be able to hand to the hospital.
Oh yeah,
that was sitting on the seat under something, and I didn't see it and find it until we were like 10 minutes away. It's oh shit, yeah,
I think the last thing for me was a bag full of pills, but that's been a while.
Yeah.
I haven't got one of those yet. I'm sure
I love the bag full of pills.
Yeah.
That's about that's right up there with like the shoebox full of medication receipts.
Yes. Yep. Watching the medic go through medications, expired. Now this is good, expired. And by the time he was done, there was like 3 bottles that weren't expired medications that were like over 3 years old.
Yep.
And then at the end of this all, you've done everything. You've got the patient there. You've got the patient on the hospital bed. You've done the transfer expertly without disturbing the patient because you're awesome. You've gotten all the things signed you need to get signed. You've got all their effects there. This is when you need to get that release. And this is where you ask them, are you good? Like, do you need us to do anything more for you? Because they may be short-staffed. They may be crazy busy. They may need you, for removing the patient. Maybe they have to go to another part of the hospital. Like, make sure that you're good to go and that they're okay. And then get that release form signed, and then you go to the next step.
Run
as fast as you can to the break room, which is where you get the good. This is the whole reason, really, that we're taking the patient to the hospital. Is if it has a good break room and it's got all the snacks and they're free, and they don't mind when you grab fistfuls of them and shove them in your hoodie pocket.
Oh, they absolutely mind.
They do.
But I think the most experienced pillager amongst us is going to tell us about the process of terminating a call.
Yes.
Yeah. So there's going to be a point you've taken the stretcher back to the, it's been cleaned and wiped off. You're taking the stretcher back to the ambulance. It's funny, in our notes, we one of the things that was talked about was the documentation is done. There was a period of time where we did have to wait at the hospital and finish the documentation before we could leave because we had to provide them a printed copy of our report. Thank God we don't do that anymore. It was awful for somebody with ADD. Me, that's the person I'm talking about.
It's me. It's me.
Yeah, we do.
But you should work on your reports and get them done as soon as possible. So we need to make sure our equipment is cleaned and replaced. Any of the supplies we used. Sometimes you have a exchange program, a 1-for-1 exchange program with the hospital for certain items. You make sure you get those if you absolutely can, and you want to make sure the ambulance is in a state where you can run another call immediately from the hospital if you've got to.
Because you may have to.
You may have to. I've definitely done some hot swaps on patients. Here's the report. See you later. I'll be right back.
Yeah. I mean, it depends also where we have one hospital that we bring patients to often, the one I mentioned in Allentown, and like that one is far enough outside of our coverage area that we actually can't go responding until we drive a significant distance away from that back home to then be responding again. So we won't get called until we're out of there.
I have definitely responded from the hospital a bunch.
Yeah, well, the other hospital we go to is like right inside. So like that one we respond to from right away.
So again, you're going to go to the restocking room and get all the things that you used on the previous call. You're going to make sure the stretcher is wiped down and clean. You're going to put new sheets and blankets on it every single time, right? We're not reusing blankets and sheets.
You can just flip it the other side.
By the way,
it's not like underwear, Max. You can't wear them for 4 days.
Pro tip, by the way, if you are not the one giving the patient care report or the handoff report, you should be the one putting the new set of sheets on the stretcher, getting that ready to go. It's no reason not to. Just get that thing ready to roll out of the hospital as soon as you can, and then get more sheets along the way. Don't use the new sheets that you get to put on the stretcher.
If you haven't had an opportunity to get lunch, or you need a snack or something, this might be the time you hit the EMS lounge up. EMS rooms are not all created equally, and we could do a whole episode. We could do a whole episode on that.
Yes, we really should.
We should. But this might be the opportunity to grab a little snack, use the bathroom if you need to use the bathroom. Figure out which Uncrustable flavor is your favorite, and grab a handful of those.
That's the real question.
Well, grape is a solid answer, but they also have a peanut butter and honey flavor that is top notch.
Yes.
So,
and we can all agree that strawberry can go rot in hell.
Don't be bringing that strawberry into my ambulance
at 2 a.m. when you're desperate and it's all you got. Come on.
What?
I think I would deny the strawberry Uncrustable at 2 a.m.
Well, the real question is, Mike, would you eat a cheese stick that is opened and may or may not have had a bite taken out of it if you were desperate?
Ooh, versus a strawberry Uncrustable?
Yeah. For our listeners, that's a reference to our episode that we did with the EMS 2020 guys. They're great. They had us on their show. So if you haven't listened to that, go check that out.
Jonathan came out swinging in that episode. We call him in, and all of a sudden he's dropping bombs about Uncrustables, making everybody laugh. I was super jealous. I'm like, man, that's the funniest thing I've heard in a while. But yeah, the Uncrustables, man, that's like, EMS 101. You gotta be down with the Uncrustables. Mm-hmm. You have to have a favorite, or else you're just weird. And don't be
so. As Mike was saying, hey, if you aren't, participating in the patient handoff, you should be, getting everything ready to go, getting those supplies. That you may even go ahead and go back out to the ambulance and start to clean up anything that's in the back of the ambulance. Now, sometimes you can't help it. It may look like a bomb went off in the back of the ambulance.
It's going to look like a bomb went off in the ambulance.
Sometimes it happens.
Maybe.
But if you're in the back of the ambulance, you should do the best you can to consolidate your trash if you're able to. Don't be a jerk.
Well, that's what you do when you're waiting for them to take 5 hours to do the damn sign-off so you can leave.
So during all of this is a time where you may use a red biohazard bag. You're definitely going to want to wear your gloves. You might pull out the purple wipes. If you haven't seen the purple wipes, that's an initiation in EMS. But basically some sort of disinfectant wipe. You may wipe down all the high-touch surfaces. You may have to clean up any sort of mess that was made by you or the patient, and that might include bodily fluids. And if you had extra linens that weren't on the cot, you may, take them into the hospital and, put them in the dirty linen bag.
You know what my least favorite thing, I mean, I'm sure there's going to be more least favorite things like bodily fluids to clean up, but those freaking, the lead pads, the little paper that falls off when you're like peeling it off, like the 12 lead, electrodes. Man, those things get everywhere. Like,
yes.
And
do.
like when you're wearing gloves, you're trying to pick them up off the ground, and you're just like, come on, like you just can't pick them up off the floor. Those Lancets, like the
Lancets.
from like glucose testing kits. Like they just, no matter what, there's no good place to put them. So you put them on like a surface and they just go everywhere in the ambulance.
Yes.
I think my like pet peeve as far as stuff is concerned is the buffer tubes that are at the end of IV catheters, right? So they act as a one-way valve, and they usually get removed when you put a hub on the IV catheter, and those things will find their way into every crevice of an ambulance. But yeah, so in general, not going to belabor it. This is your time to replace equipment. If you used your suction, you may you may replace that and get a new canister, new suction catheter.
If you can.
If you can.
That's one of those things, like the hospital may not have the equipment for you to replace. Like it depends on the hospital, right? So most of the time you can get some stuff at the hospital, like the linens. I would assume most hospitals are going to have sheets and blankets for you, but like I've been to places where they're like, oh, well, we can't get IV start kits from this hospital, or we can't get this hospital doesn't have a BVM. Like we have to pull from our own inventory. I'm like, okay, that's weird. But it all depends.
Yep. Here's an additional thing. If it's appropriate to do so and you're not going to inhibit the patient care at the hospital, you should try and get back any equipment that you may have used to move the patient. That could be a Reeve stretcher, that could be a mega mover, that could be a backboard and spider straps. Any of these type of things, if it's not going to keep the patient from getting the care that they need, you should get those back as soon as possible. And there may even be a room in the hospital where maybe from not this patient, but from previous patients, they've been stacked in. So you may want to go check that room and see if you can get that equipment back and put it back on the ambulance after you've deconned it.
Yeah.
So make sure you get your equipment exchanged, your supplies if you can. Make sure the cot's ready to go, the monitor's put back. These are all important parts of making sure the ambulance is ready to go back in service. And once all that's been done, at this point, you're going to hop in the ambulance. And Mike, why don't you take it from here and tell us about that process?
I get to talk about the last thing, the final section. And a lot of the stuff, is going to be familiar in here. And I'll quickly go through this in terms of like the key things to remember. At this point, hopefully everything that we have in the ambulance is ready to go. And, we can call when we're leaving the hospital, and if it's something within your service area, you can say, hey, we're in service, or leaving the hospital, and then you can go in service when you enter your service area, and hopefully you can just keep rolling right into whatever the next thing after that. But optimally, you're heading back to quarters, right, or the station or the house, whatever you call it, right? That's the goal. But there's some things we need to worry about on the way. Because while we've made the ambulance ready with all the equipment and stuff within there, we have to ask ourselves, are we ready? Like, that's probably the biggest thing that I've found about my own like journey in this, is that, man, that adrenaline letdown after leaving you're rushing through everything, you're getting everything ready, you finally get back on the ambulance, and like it's late. And that adrenaline goes away, and all of a sudden you're like, man, I feel sleepy. And, now I have a 15-20 minute ride back at night. And that's, I think, one of the biggest opportunities for things to slip, and for, chaos or Murphy to pop his head in and, all of a sudden catch you off guard. And that's where we need to, make sure that we're staying cognizant, that we're helping our partners too, to be like, hey, are you doing okay? Do you need me to drive? Do you because that can be very taxing on the body, is like getting to that point where you're just running on fumes, right? That's the big thing, making sure that everyone's still okay and that we're getting back safely. The driving is the big thing. Yeah, you're not driving lights and sirens at this point, but if you're groggy, that's probably more dangerous than any other type of driving. So yeah, do all the safety things, wear seatbelts, drive safely, keep an eye on your partner, make sure you're backing each other up, right? You're letting dispatch know that you're ready. That's the big one. You may have to air out the ambulance. Like if it was a particularly smelly call, you may have to open up the windows along the way. That could be a thing. You may have to deal with that when you get back to quarters as well. We'll talk about that in a second. And the thing that you can't neglect is you need to get fuel. Because sometimes you're going to expend a good portion of that in whatever call you were just on. And you can't go back to quarters just to be like, oh, you know what we need to do before we go respond to that next patient when the tones drop is we need to go stop and get fuel. It's one of those things that has to happen before the next call. Like it can't be
It's
during.
completely appropriate just to pull over into the Wawa, tones are going and say, oh, we're going to be ready in about 5 minutes.
Hold there 1 minute. Hey, by the way, while I'm filling up, can you go grab me a pretzel from inside?
Yeah, right, right.
I don't think that would go over well.
No, I don't think so either.
So make sure you grab fuel, like in the ride back. Okay, so you've ridden back. You're back at quarters. You may be required or asked to call like dispatch when you're back at quarters. In our service, we don't have to do that, but I've heard of that being a thing. And that's the point where, and I forgot to mention, if your ambulance is super trashed, like, hey, we cannot get this thing back in service until we are back at quarters. We've had a chance to like really wash this thing down or grab essential equipment that's at our service. You're not in service. You should not be in service unless you are ready to go and pick up a new patient. That's why we have other units out there. Hopefully we're in areas where we have some backup, but you can't go in service unless that ambulance is ready, right? So that may require going back to the station.
And that includes the personnel too. Like you have to be critical. As much as you need to watch your partner, it's not that it's harder to be critical about yourself and be honest about where you're at. And if you're not an effective team, then you need to make that call.
Yeah. So when you get back, you may have to do some regular cleaning type stuff. Depends on how bad the ambulance is. You may have to restock supplies from your station, depending on what you carry, depending on what you used. It's all going to be kind of situation dependent. But you need to restock the ambulance. You can't run the service without essential equipment. Things that we learned in our minimum equipment list. I think it was last episode or the episode before. Yeah, it was the getting ready episode. So we have to make sure that's in place, right? And this is the part where we may have to do a little bit of even if the ambulance is ready to go, there may be some lingering odors and things in there that we wish to not endure further. So we may need to open that thing up, open the garage bay, the garage doors, and maybe even I started learning about things, seeing them on social media recently for like coffee. Nebulizers. It's not for you to nebulize coffee for yourself. You put the coffee in the nebulizer and you let that go in the back of the ambulance. And apparently coffee does a pretty good job at removing odors. I've seen, I can't condone this. Don't say you heard this on the RideAlong EMT School podcast, but apparently people put things in the nebulizers and then obviously throw the nebulizer away. But you can aerosolize things that smell better than whatever else is in there. So, hey, we have to be resourceful sometimes in EMS. You may have procedures and things that you have to do maintenance-wise, like disinfectant things or like washing respiratory equipment. I don't know. Maybe if your ambulance service runs a ventilator, you may have to do maintenance or disinfection on a ventilator. This is just throwing something out there that could be there. If you need to do that stuff, do that stuff.
The laryngoscope.
Oh, yeah. A laryngoscope is probably a good example of something that needs to be sterilized because it's not disposable.
I remember the first time basically brand new EMT working a cardiac arrest, and they hand me this laryngoscope covered in like all sorts of gunk and funk and that sort of thing. And they're like, here you go wash this in the sink with, this soap. I was like, well, where'd this soap come from? Oh, we got this from the funeral home. My eyes were as big as saucers, but I went and did it.
Yeah.
I could so see like a new EMT coming out and saying, "I need to restock that laryngoscope." Why? Well, I threw it away. It's one use,
Ooh.
right?
Oh,
I could
I don't know,
totally
this
see that happening.
sounds like ALS stuff to me. Like
Mm-hmm.
let those guys worry about the laryngoscope.
Mm-hmm.
But yeah, so if you are responsible for doing those types of things, you need to do them. That may even require washing the exterior of the ambulance. I don't know. Like, that it's going to be dependent on who's running your service, right? And what their rules are. But lastly, the thing that we want to do here is recharge, not the ambulance, not the equipment, but ourselves. Relax, wash up. Like remember, you can't just wash the ambulance. Sometimes you need to do some self-care too. So make sure that you're taking care of yourself. If you have soiled clothing, hopefully your ambulance service has some sort of facility where you can like swap clothes out or get washed up. Like if you got, clothes covered in blood or other things, man, it would sure be nice to be able to swap those out.
Showing up to a pediatric
I need to start
call
carrying,
and you're covered in blood.
Yeah, I need to start carrying an extra set of clothes just in case.
Yeah.
Pro tip: carry an extra set of clothes in the ambulance.
Yeah. And try not to bring that stuff home if you don't have to. Like if they have laundry facilities there, wash them at the station so that you don't, gunk up your own stuff at home. And relax, eat some food, go to sleep, recharge, do what you need to do so that you're ready for the next one. And that's pretty much the end of this. And now we're back full circle with where EMS operations started 2 episodes ago, where we're waiting for the tones to drop and we're ready for that to happen. So hopefully these episodes have given you a bit of a sense of the cycle of EMS and what we're doing. And obviously that can change. Sometimes you may be on one call, drop a patient off or get canceled, which we actually didn't really get into, which we should probably talk about at a later episode, is like cancellations and or patient refusals for sure.
Yeah.
So we'll definitely talk about that. But those are kind of non-standard things, or maybe not non-standard, but all things that can happen along the way. And then, you may roll right into the next one. So it's all part of the process. And it's just like, the things that we've learned to kind of experience as part of this process. But yeah, so EMS operations, we finally made it to the end, but there were a couple of things, especially in this episode, that we started talking about, is a tool that was so ubiquitous with the idea of patient care that I'm surprised we actually didn't talk about them before, because you may overlook them. It's the thing that you're like, if your partner's doing the verbal handoff, your job is to get over there and start getting things ready on the stretcher. And the one thing that will, is pretty ubiquitous is sheets
and blankets,
making that stuff ready for the next patient to use the stretcher. And Max is going to tell us about those in our tool of the trade this week.
Yeah. So the linens that are on the ambulance, it's something that you're literally going to put your hands on for every single call. You're going to touch it for every single call, even if it's just to remove it off the cot. And you're using them to cover the cot. You're using them to help warm a patient. And you're also using it to help transfer a patient from the cot to the bed in the ER. It is something you are going to have hands on every single call. An ambulance typically carries a specialized section of disposable fluid-resistant medical linens specifically designed for the patient comfort. So not necessarily disposable, because some services apparently have that option. I have not seen it in my service. Everything that I have seen in our service has been something that was left with the hospital to be laundered. And generally we're dealing with flat sheets, and we're dealing with blankets. It's usually a very thin blanket. It is not really meant to be overly warm. It is something to wrap the patient in.
If you need more warmth, just add more blankets.
Add more blankets,
yeah.
Which I've done more than a few times. Or for that matter, if the blanket doesn't quite cover the patient, you might be using multiples to try and get them snugly packed.
Yeah.
They're generally fluid resistant or impervious, depending on what they are. They do have fitted cot sheets. We haven't seen them in our service. All I've seen in our service is just the flat sheets. And that's just that first layer that you're going to put on the cot between the plasticized cushions and the patient. There's also some other things you may find, like incontinence underpads. They're highly absorbent pads that are placed directly under the patient, but the underside of them is impermeable for fluids. And those are also generally laundered through the hospital as well. And then obviously towels, washcloths to clean the patient up off and dry the patient off if necessary. And those are also things that are getting laundered through the hospital. Most hospitals, when you walk through the hallways, you're going to see bins for laundry, which you're going to drop your stuff into, even if it's something where you didn't maybe it's something you didn't transfer the patient over on. Any of these linens that have been in contact with the patient or fluids need to be put into the laundry for the hospital.
Even if it doesn't look like they need it, you just swap them out. Like one patient, one set of linens goes in the laundry, and then you restock it. And
like we talked before earlier in the episode, most hospitals are going to have an EMS area, and they're going to have linens that you can switch out. So what you're doing is you're basically going one for one. And that is something that started back in the 60s with a one-for-one swap with the hospitals, which takes needing that infrastructure away from the ambulance houses and has basically the hospital take care of all that stuff. So I think that for hospitals, for ambulance services, that's huge because they don't have to worry about washing all these linens all the time.
Well, the hospitals are going to be doing it anyway. Like they have hundreds of beds.
Exactly.
And they need linens for all the beds. So to have a rack of linens ready to go for cots and stuff makes a lot of sense.
Most hospitals nowadays have a vendor that they go through for that service.
Yeah.
And so they send them out to a vendor, and then the vendor sends back
just
fresh
big old bins being put
sheets.
into trucks,
which makes sense.
Yeah. Hey, if you're doing EMS and you've ever grabbed a fresh set of linens and opened them up to put them on the cot, and you've discovered an electrode that's stuck in there, go ahead and drop us a message.
I had one. I pulled a sheet out, and I wasn't really paying attention because I generally will do that. I'll be the one that sets the stretcher back up again, and I put it on, not really paying attention. And one of the guys walks out and he says, "Let's get another sheet." And I was like, "Why?" Like it's on there, and I look over, it is just completely stained with blood from top to bottom.
Mm-hmm. Yeah.
And he's like, "Why don't we put that one back and get one that is not? It's washed, it's been disinfected, it's clean, but not covered in blood stains."
And that's
probably a good move.
One of the things that you had mentioned before, I'm sure there are services or hospital systems out there that have linens that are impermeable or less permeable, but all the ones I've seen are just straight up cotton sheets.
Yes.
And they will stain. They all have stains on them. They all have, they are not the prettiest looking sheets in the world, but they are clean. So that's that's the only downside of them is that they may not look like they're the most, pristine thing.
And I think of all the tools of the trade that we have talked about, I would say without a doubt, this is probably the most hands-on contact we've had
with any tool,
period. Like every single transfer I have done at a hospital where you're transferring from the stretcher to the bed has been with the sheet that was on the cot.
Right.
Like every single time. So it's one of those things you're not going to really think about, but it's something you're using every single day.
I think they're so ubiquitous to EMS, like the idea of linens and sheets and blankets, that I have not seen an ambulance that doesn't have a dedicated sheets and blankets cabinet.
Sure.
Okay. So, all right. Yes. But I did the contract I just got off. They would have one of everything as the spare.
Oh man.
And it drove me nuts. Absolutely bonkers. Because I'm like, where the hell are the blankets?
Well, the funny part is my hometown service, there's a very big kind of push from the paramedic team there that they're like, we don't want our ambulances overstocked because overstocked drawers mean that it's harder to find things. Totally understand. Like, you don't want a super amount of clutter in there.
Yeah.
You want enough to get things done, right?
Yeah.
The one thing nobody ever complains about is having like a bunch of linens. Like,
Yes.
they're like, well, that cabinet is meant for linens. It should have all the linens. Like,
Yeah.
like they're like, there's too many tourniquets on this ambulance, but there are not enough blankets. Like, we
Exactly.
need, like, we'll go in, we'll drop off one patient and come out with 6 blankets. We didn't even use a blanket for that patient, but no, we need to make sure those things are stocked.
I have seen, not saying who or where, but I have seen the sheets that came from the ER go directly from the ER into the ambulance house, and onto a bed.
Oh, yeah.
I have seen that more than once.
Yeah.
And
Oh,
I'm
I've-
like, why are you carrying like bundles of blankets and sheets into the ambulance house? I don't understand what you're doing.
I have
And I
100
look in, and he's making his bed with those things.
I have 100% grabbed a blanket from the ambulance to take a nap.
Yeah,
I think that's a rite of passage in EMS.
probably.
Hey, if you've ever used the hospital linens to set your bunk up,
Let us know.
Let us know. Yeah, for sure.
No judgment. But yeah, so linens and sheets and blankets, basic stuff. Make sure you have what you need.
Yeah, that's a good one. You know, you're going to lose them. Use them a lot.
Yes.
All right. Well, that's our tool of the trade for this week, and I think that means we're done and we get to just leave. And
Right.
there's no little test for me and Max at the end of this episode where we have to like test our. No, I guess we got to do that.
We're gonna
Not so fast, fellas.
We're gonna dominate it. It's gonna be not even a thing. We're gonna get 3 for 3, like we've been doing.
Well, if I remember correctly, last week I had one where when I forget, there was one in there where I was like,
Yes.
I don't think I had the right answer, but
well, we're gonna go 3 for 3. So I'm saying like we're gonna succeed in our complete and utter dominance of test prep.
yes, okay,
We're dunking on it. We're just gonna dunk on it over and over again to the point where it just gets tired of that basketball smacking into the face.
Well, I guess that means it's up to you, Jonathan, to try and stump us with a set of questions this week for our student test prep.
Yes, indeed.
All right, I'm ready. Are you guys ready?
No.
Yes, sir.
Hold on. I forgot that you sent us the questions earlier. But I try not to I don't read them. It's like the one thing I
Same.
make sure to not read because it'd be weird if I tried to see.
I
the
want it to be
question.
fresh.
All right, I'm up.
Okay. All right. Question 1. A 28-year-old patient involved in a motor vehicle collision is found still restrained in the driver's seat. The patient is conscious and alert and reporting neck and back pain. Which questions or command best helps assess for a possible spinal injury during neurological assessment? Answer 1. Can you lift both legs and hold them in the air? Answer 2. How did the accident happen? Answer 3. What is the day of the week? Answer 4. Can you squeeze my hands?
There's actually not there's a couple answers in here that I'm leaning towards. There's one that I'm 99% sure this is the right answer, but like there's other ones in here I'm like I would do those too.
You want to take it?
I guess. So okay, it's a 28-year-old patient involved in a motor vehicle collision, still restrained in the driver's seat. Patient is conscious and alert, reporting neck and back pain. Okay, so mechanism of injury is a motor vehicle accident. Which question or command best helps assess for possible spinal cord injury during their neurologic assessment? Okay. So we want to look for a spinal cord injury. So what we're looking for is neurological deficits, motor deficits. We're already told, hey, we don't have any like cognition problems, right? The patient is conscious and alert, and the spinal cord injury doesn't seem to be affecting that in any way. So we look at, okay, so the first one, can you lift both legs and hold them in the air? Well, I think any patient that's been in a motor vehicle accident probably would be in a lot of pain. Lifting both legs, holding them in the air is not really a standard assessment tool.
Right.
So I would move away from that one right away. Also, there's a bunch of patients out there that wouldn't be able to do that regardless. So,
Yep.
like, we deal with a lot of patients that don't have great mobility in the first place. How did the accident happen? That's not telling me anything about their spine. Like they could say, "Oh, I was in a bad accident." Okay, but it's not telling me anything new. I already know that they're cognating well.
Right.
What is day of the week? Same thing. Same thing. And then, can you squeeze my hands? That is the thing that's going to tell me, are they having any deficits in their extremities, whether or not it's equal and bilateral. And that's the thing that's going to tell me if they're having some sort of spinal injury that is affecting their motor ability. So
Right.
It's not to say I wouldn't ask the other questions. I definitely would. And I would ask those to make sure that they are alert and oriented. I would not ask them to lift both their legs and hold them in the air, though.
No.
But for me, the answer locked in is, can you squeeze my hands?
Yep. And I agree 100%. And I think the statement of is found still restrained in the driver's seat completely rules out the lift both legs and hold them in the air.
Yeah.
To me, like so they're restrained in the seat in the car. So for me, like that definitely ruled out that. So yeah, I went the same way.
Okay, you guys are correct.
Nice.
And that one was a little tricky in the wording, and you really have to think through it, right? So the word best says that, like you said, Mike, you may ask these other questions, probably not that first answer, but you may ask those other questions or give those other commands. And this is the one that lets you know whether somebody has, potential for spinal cord injuries. And if they have one high enough up, they may not be able to do this.
Right.
So, all right. Sweet. Question number 2. A 66-year-old male reports dull pain in the right upper quadrant of his abdomen and a general sense of fatigue. You observe yellowish discoloration of his skin and sclera. During your secondary assessment, you obtain a sample history. He states the pain began gradually 3 days ago. He denies trauma, and he has no known allergies. He reports recent fatigue, reduced appetite, and occasional nausea. Based on these findings, which condition is most likely?
Okay. I'll take this one.
All right. Let me read the answers. Let me read the answers to you first.
Sorry.
I know.
I'm jumping.
All right. So the first answer is hepatitis. The second answer is pneumonia. The third answer is pancreatitis. And the fourth answer is chronic renal failure.
So when I looked at this, the yellowish discoloration of his skin immediately put me towards his liver being the issue.
Okay.
And that the fact that he's talking about the right upper quadrant also works with the liver. Pneumonia is going to be a lung issue. It's not going to be an issue with his liver. Pancreatitis, same thing. That's going to have to do with his blood sugar levels. Chronic renal failure, no. So I would land on hepatitis because that's the one that affects the liver directly.
Okay.
So that's where I would go.
Yeah, I'm in the same camp. I don't just to double check you, Max. I don't think pancreatitis affects the blood sugar levels. I think that's
inflammation of the pancreas.
Right. Yeah.
Okay. Sorry.
Yeah.
Sorry.
I don't, because that would be a diabetic issue, but pancreatitis is a problem with the pancreas. So you're on the right track. It's just
right.
That's like an inflammation of the pancreas itself. But yeah, so like the yellowing of the skin, like to me, that's the it's jaundice, right? Like we're talking about the liver there. So I'm on board. Yep.
That is correct. Hepatitis would be the answer, right? So, yeah, that jaundice is, and when somebody is really in hepatic failure, you will see it. They will be as yellow as that monster can that's right there with you, Mike.
You could have told me this was green. I would not know.
That's right.
I've actually, my dad had cirrhosis, and I've watched him, and it's crazy how fast it changes.
Mm-hmm.
Yeah.
Like when he was having a bad spell or having issues, like he went from a normal skin tone to that yellowish skin tone. It took like no time at all. It was absurd.
Yeah, this is one of those questions that like kind of annoys me because it's asking you to pick something that is, well, I mean, how our job isn't necessarily to pick like these conditions out. It's really to help kind of assess what symptoms we're seeing. So with these symptoms, it could be a bunch of things. I think if we walked into an emergency room saying like, "Hey, I think this patient has hepatitis," it would probably be a little bit presumptive. But
Right.
but to say, "Hey, you know," because that could be and like a bunch of different liver issues. But saying it specifically like, "Hey, pretty sure this patient has hepatitis," is kind of presumptive.
Yeah, agreed.
Right. Yeah, I mean, even just saying the symptoms, like, "Hey, this patient has was there abdominal pain?" Right, like this patient has abdominal pain and jaundice, right? Like those,
Yeah.
that's what you see, right? Like that is, and let them figure out the diagnosis
Yeah,
side of it.
and they even identify the quadrant too. So
Yeah.
like giving him all that information.
Yeah, exactly. Yeah, and it's really trying to
Right.
test you in that, hey, I know that jaundice is likely associated with the liver, and then liver is associated with, hepatic issues. So hepatitis is a liver issue. So like you're trying to make, connect the dots between these things.
Yep.
And limit and rule out other things. Cause like none of that says anything with breathing problems. So pneumonia wouldn't be
Right.
something that's in that list.
100%.
Can we? Yes. Will we?
Yes, we
Who
will.
knows?
It's going to happen. This is one of those that could be a bunch of different answers. 100%.
Yeah, maybe. Well, it's asking something very specific, right?
It is.
So the first question we have to ask is, what's the difference? What does objective mean? So objective means hard evidence, things
Right.
that are measurable or definitive, versus subjective, which is feeling and perception, right?
Yeah.
So that's what we're talking about here. So of these four answers, are there some that stand out as being things that have information that are subjective in them?
100%. I think there's two answers. I know what I landed on, but I think there's two answers that give you objective information to a certain extent. There's two answers that are very subjective.
Okay, well, let's break each one down. So patient states he has difficulty breathing for the past hour. Is there anything subjective in that?
Yes, because it's his perception of time.
I would say it's yes, but because what does difficult mean?
Right.
Like that can be, that's subjective, right?
That's
like
100% subjective. Yeah.
Yeah. All right. The second one, patient reports a history of asthma and uses a rescue inhaler as needed. Is there anything subjective in that?
The as needed portion, because he says he has asthma, but there's no information of the last time he used it. There's no information of it is as needed. So you don't know if it's something that he does on a regular basis or not.
Yeah, I would agree. Like there is some subject. I think that one is more objective than the first one.
Yep.
But there is some level of possible subjectivity in that.
Right.
So patient describes a sensation as not being able to get enough air.
100% subjective.
Yeah. Like sensations,
Yep.
not being able to get enough. Like what is the objective measurement of that? And the last one, respiratory rate of 28 breaths per minute with visible accessory muscle use. Is there
the
anything?
most objective statement.
Yeah, it's totally objective. It has a measurable description in the 28 breaths per minute, and visible accessory muscle use is very specific as to what it's saying.
Yep.
So I would say the fourth answer is the most correct, with number 2 being pretty close. Like patient reports a history of asthma and uses a rescue inhaler as needed. That's prescribed
It
language.
is.
But
Yeah, 100%. I mean, if there was a second best, that would be it. But the reality is the giving an actual rate of breath and an actual observation makes it the most objective answer.
I would agree.
So that's
I
where
think
I
it's
landed
4.
to. Yep.
Yeah.
Yeah.
Oh man. Nice.
Now, question. So, if answer 2 had been changed to use the rescue inhaler 10 minutes before arriving, would that make that statement as objective as the other?
I don't. Yeah,
No?
like I honestly, that answer. This is one of those tricky ones because I really don't think there's anything subjective about that answer. I just think it's like the patient reports, like anything the patient says is going to possibly have subjectivity to it.
Yep.
A history of asthma. What does that mean? How bad is the asthma? How often does it happen? There could be some questions in there. And a rescue inhaler as needed. I don't even consider that to be totally subjective because that's literally what the indication is of a rescue inhaler. So
Right.
I think it's more along the lines of the patient reporting something versus you observing something is the level of objectivity.
And I think this is a perfect example. I think maybe one of the best ones we've seen of, in my opinion, of the answers that are trying to trip you up and where you have to really be critical in when you're testing and reading that question. Because if you had glanced through that question, you could have gone to either one of those.
Yeah. Well, it's also hard because it's asking you to understand medical stuff.
Yep.
And logic. Like, you know, like kind of English logic in terms of like objectivity versus subjectivity and understanding like, you know, a more broader concept of those things versus just a medical term. You have to assess the actual, like, you know, is this objective or subjective descriptions? So, yeah, it's a tough one. But
the important part is we went 3 for 3.
Yeah.
That's the important part. That's all that matters. Forget the learning for the listeners. It's about us going 3 for 3 each and every week.
You know what I think we should do, Max? I think in like end of the year, you and I should take a practice test.
Yeah.
And see what our number is and see if we if we still got it, you know, like a full on practice test to see if we pass.
Yeah, but I want Jonathan's sweet Southern voice to read the question
every single one of them.
Every single one of them. So what I need Jonathan to do is
I think Jonathan has to take the test with us. Like I think he also has to take a practice test. Oh, that would be fun. That would be we'll have to make that happen.
That the ego would just be stabbed repeatedly with a sharp knife.
just see how much he rips us apart. It is
exactly.
It's superior medical knowledge.
Well, thank you, sir, for those questions. They were excellent.
Yes. All right. So you guys got anything else for this one?
I think we're good.
I think we hit all of the operations.
We've wrapped up EMS operations.
Yeah, we've operated the operation
because we're operational and operating. Yes.
But yeah, so thank you guys. We appreciate you all listening. We hope you're enjoying it. We hope you're kind of going along with us, that this is useful for you, and that you're kind of getting a sense of not only what we've learned in school all those many months ago now, but also how we've been able to take that and apply it and start understanding it in the context of the real world.
Yep.
I'm sure we look at this much differently than we did when we first started, but it all starts to make sense. I promise you. Like you will,
Yep.
It is totally understandable, and you can do it. And hopefully you believe that too, because we do.
Yep.
But yeah, so thanks everybody for taking the journey with us, and we'll see you next time on the Ride Along. This podcast is for educational and storytelling purposes only. It is not medical advice or official EMT training. Always follow your accredited instructors and local protocols.
Heartbeats racing in